The study session for September 19th, 2022 is called to order. Would the clerk please read the roll?
Mayor Kaufman? Mayor Kaufman?
Here.
Mayor Pro Tem Bergen? Councilmember Coombs? Councilmember Gardner?
Here.
Councilmember Jurenski? Councilmember Jurenski? Councilmember Lawson?
Here.
Councilmember Marcano?
Present.
Councilmember Medina?
Here.
Councilmember Murillo? Councilmember Sundberg?
Here.
And Councilmember Zvonik?
Here.
There's a quorum.
No mayor's update. Are there any issue updates? Seeing none, is there any objection to moving the consent calendar item number 2A or 2I forward? Seeing none, the consent calendar item number 2A through 2I will move forward. At this time, I'd like to move item number 5C. Let's see here. 5C forward. And let me recognize Councilmember Jurenski. She's here. Councilmember Jurenski here. Councilmember Gardner.
Mayor, I have a question of the city manager. Is he on the call?
City manager.
Yes.
So, Jim, you and I had a conversation this afternoon, and I asked you to let me know if we were moving this item up so our presenters could be here. Why wasn't I informed of that?
Yeah, I apologize for that, council member. I just realized that 15 minutes ago that was the case, and I apologize.
This is really disappointing that we're doing this, but I'll proceed. Hopefully we can get our presenters on the call. But anyways, so the item before you is a resolution to ban the introduction of new sedatives within the city of Aurora. For a little context, in August of 2019, Elijah McClain died in our city as part of the interaction with the police and fire. He was injected with ketamine. Those several firefighters and police officers are now on trial for murder, including the paramedics that were on scene. Shortly after that incident in 2020, I brought forward an item banning ketamine usage in our city. And as most of you are probably aware, the state followed suit shortly thereafter, putting quite a few safeguards in place for the use of ketamine. Recently, our medical director, Dr. Hill, has indicated that he will be introducing a new sedative into our medical protocol, droperidol. I feel like the timing of this is wrong. I do not agree that we should be introducing a new sedative while we have firefighters on trial for murder for using a previous sedative. We have a current sedative, Versed, midazolam, that they have available to them, but I do not think it is appropriate to introduce a new sedative. I do recognize that the wording of the resolution may be a violation of the city charter and that it directs the city manager to direct Aurora Fire Rescue. And so, after we debate the merits of this tonight, when we bring it forward to a regular meeting of the Aurora City Council, it will be as an ordinance without that direction in there. So there are no questions as to whether or not it's a violation of the city charter. I think one of the things you're going to hear tonight is that this droperidol is a safe drug, and it may very well be. I'm certainly not a medical doctor, but we were also told that ketamine is a safe drug. We were told that ketamine was safe to use, and we have firefighters on trial for murder for administering it. And I think it's really important to defend our firefighters and make sure that they can feel comfortable knowing that the tools that we've given them to do their job will not land them in trouble with the law, will not land them to lose their livelihoods, to lose their health insurance, and potentially go to prison for murder charges. I think the current sedative from the discussions I have had with firefighters, the current sedative that is available is sufficient. And I feel like we need to resolve this criminal case before we have a discussion of any new sedatives in our city. I think Councilmember Durinsky's on the phone. And then in addition, we also have Travis Pulliam, the president of Aurora Firefighters Local 1290, and Charlie Richardson, the legal representative for Aurora Firefighters Local 1290 to present. So I will turn it over to Councilmember Durinsky.
Thank you. I unfortunately was muted during the first part of what you were saying, but I caught the last half. And these are my sentiments as well. I can't believe that we are having this conversation. This was first sprung on me in a public safety committee meeting, and I spoke up immediately questioning this. But the way that it came forward in the public safety committee meeting was informational purposes only. It wasn't anything that we could give directive on. It wasn't anything that we could vote on. And so, you know, that this started the quest of how do we fix this, and how do we help firefighters? You know, a medical director, a deputy city manager, and a city manager are never going to stand trial for murder for administering this sedative. The 3 police officers currently on trial right now have 3 felony charges against them. The 2 firefighters on trial for murder right now have 11 felony charges against them. What this has done to firefighters, specifically our firefighters, was overwhelmingly change their morale and terrify them into administering sedatives. And, you know, it's unfortunate that I wasn't on the council when this happened to our firefighters and our police officers, and they were going through this, and their coworkers, you know, having to deal with this with, you know, the trials starting, and when these officers and firefighters were charged, they weren't supported. They weren't supported by the previous council. They weren't supported by the current city administration, and we have a chance to right that wrong now. And we have a chance to stand up for them now. They're absolutely terrified. This isn't anything that they want to do. And it's time that they be heard. One thing that I've been told is that it's going to be brought up to us that we need to make sure that the police department cannot order or encourage the use of any sedatives. And to that, I just want to point out that is actually already in the consent decree. So there's no reason to add this into our now what's going to be ordinance. It is in the consent decree. So I just want to state that, and I absolutely am against this. And again, I cannot believe that this is the conversation. I cannot believe that this hasn't been stopped. I had a conversation with Jim Twombly, and he understood this, and he actually agreed when he and I were on the phone. I got a phone call from the fire guys thanking me for standing up for them, and that the interim chief, Rob Knapp, had told them that this was going to be put on hold. So we felt confident. 3 days later, I got a phone call back from the fire guys saying that, from Chief Rob Knapp saying, well, Councilmember, we don't know what happened, but now we've been told that no matter what, this is going on the truck and we're ordered to use it. So I don't know what happened, and maybe Jim Twombly would like to speak for himself. But something doesn't seem right here. And I just hope that a majority of my colleagues will agree with Curtis and I, that this is not the time to have this conversation. And with that, Curtis, you can direct anybody you want to talk about this.
So we have, again, Travis Pulliam and Charlie Richardson on the phone. Are you guys there?
I'm here. Thank you.
Charlie,
Can you hear me?
yeah, please proceed. You have 3 minutes.
Okay. Thank you very much, Mayor and City Council. With me is Travis Pulliam, and I will go first. He will go second. Please ask any questions when we're done. I'm going to talk about the criminal case. It's already been alluded to. I'm going to talk about the rumors about lawsuits, and finally, why a resolution. The police, it's an average of 3. 2 of the police officers were charged with 3 felonies and 1 SE. Now, when I say SE, I mean sentence enhancer. It means essentially mandatory prison. and longer prison sentences. So 2 of the police officers were charged with 3 felonies and 1 SE. A 3rd police officer was charged with 2 felonies. Now I'm going to read the counts against both paramedics: manslaughter, felony, criminally negligent homicide, felony, assault in the 2nd degree with a deadly weapon, violent crime causing death, that's a sentence enhancer, violent crime, use deadly weapon, sentence enhancer, assault in the 2nd degree by drugging a victim, that's a felony. Number 7, violent crime causing death, that's a sentence enhancer. Number 8, violent crime, use deadly weapon, sentence enhancer. Number 9, assault in the 2nd degree causing serious bodily injury, that again is a felony. Number 10, violent crime causing death, that's a sentence enhancer. Number 11, violent crime, use deadly weapon. Now, the Civil Service Commission does a great job in getting the best and brightest to be our firefighters. And so they are acutely aware of the significance of what can go wrong with chemical sedatives. And since I'm on the phone, you apparently cannot see me. Is that correct?
Correct.
Yes.
Right? Okay. I brought 2 of my own syringes to show council, but these syringes are classified now as a deadly weapon. And so the paramedics are aware of that. Let me say the union would never tell a firefighter not to use a chemical sedative. But what we are doing is that we're telling our 405 members of the potential serious criminal charges, administrative charges, civil liability, and candidly, we tell them if you're in an incident, the city will drop you like a hot potato, and then it's your faith, your family, and your union's legal defense fund. That's all there is. Now, there are rumors about, oh, there's a viable lawsuit if you pass this ordinance now. Most legal opinions with any credibility are in writing. They cite learned legal treatises, they have statutes referenced, they have regulations, they have precedential case law, and even constitutional law when necessary. You know, I worked 38 years for the city, and I never saw the city council be intimidated by a threat of a lawsuit. And I hope this council isn't the first council that shies away from doing the right thing because of a threat of a lawsuit. Now, there's a rumor out there that the city attorney's office is saying that this lawsuit might have validity. Well, again, I want to see that legal opinion because the city has sovereign immunity. And I'm not sure about this tort of interfering with medical practice. So we are real skeptical about that. Finally, if the firefighters are already balking at administering this, would balk at administering this new sedative, why do we need an ordinance? Well, let me tell you, for city council to strongly express its concern about the well-being of the 405 city employees and take them out of this terrible exposure they have now would mean a lot. And it would be very, very appreciated by 405 city employees. So please, we're asking you, please proceed with this ordinance. And I'll let Travis now make his comments, if that's all right.
Yeah.
Please proceed.
Mayor and council, thank you for the time. I too would like to speak in favor of this resolution, or I guess ordinance now. As all you know, 2 of our firefighters are awaiting trial. It's been just a little over a year since they were charged with these 11 crimes. And that is in relation to administering ketamine. So just over a year later, we're trying to introduce another sedative. And we, us as firefighters, me as their representative, have a very hard time with that. A little history, what you're going to hear later, I'm sure, is that this is a safe medication. It's used across the metro area. Um, to me, that's deja vu. Whenever the word droperidol said, just replace it with ketamine, and that's what we were told 5 years ago. And here we sit, supporting and or awaiting trial for two of our members with some very serious charges, of course. I don't want to repeat everything Charlie said, but our members are scared. They don't know what to do. They don't want to be the next firefighter charged with a crime for doing their job. We're kind of putting them in a catch-22 type situation where if we add this new sedative, they're damned if they do, damned if they don't. If they give it, they're going to get in trouble. If they withhold it, they're going to get in trouble. We're a pretty tight knit community, pretty tight knit family, and as we see our brothers going through this, it scares our members, and they don't want to be put in that same situation. As president, I visit stations and try to keep up with the membership and keep up with where they are and how they feel about things. One of the stories I got recently was a call off of Mississippi, and they were helping this lady with whatever medical problem it is. And once she decided she didn't want to be a patient anymore, she started running away, yelling, "Don't ketamine me! Don't ketamine me! Don't ketamine me!" So this still is in the minds of our citizens. It's in the forefront of the minds of our citizens. And then we're thinking about introducing a new sedative without any sort of community input. It just seems wildly inappropriate and dangerous to me. Other than that, I'd just like to thank you guys for your time, Mayor and Council. I encourage you to move forward with this resolution. Thanks.
Councilmember Gordon.
I believe there's staff on the phone that's going to talk about this. I don't know if it's Chief Robnet or Dr. Hill.
I have questions for Dr. Hill. Dr. Hill, are you here?
Yes, I'm here.
Okay, Dr. Hill, let me ask you the first question. What are the EMS protocols and who is the approving official for them?
So EMS protocols are written by licensed physicians in the state of Colorado. They are approved by the licensed physician who is the medical director for the EMS agency. It is the requirement of state law and regulations that in order for EMS providers to use their certification to treat patients, they have to be working under they have to be approved by the medical director to work under those protocols to treat their patients. So that's what they work as like a physician order and a treatment guideline and algorithm for them to follow.
And how often are these updated and why are they updated?
So we update our protocols twice a year, or more frequently if something's urgently to come up. They are updated for probably two different main reasons. One would be is if in the review of your calls, if we have a continuous quality improvement process where you review your medical care, review the data. If you see something that's concerning that you need to address, you may update the protocol for that. You may also update it for things like new medical research. The treatment guidelines of how to manage certain conditions will evolve over time. And in medicine, there's continually doing research, there's continual papers coming out, and that over time, will adapt when the overwhelming amount of evidence and weight of a medical research study shows that a particular treatment process is better or safer, then physicians will adopt that as the best practice or the safest practice for their patients.
Okay. And why is droperidol being placed into the EMS protocols?
So we monitor and scrutinize every use of sedative in Aurora very, very closely. This has been done individually by myself for the last 2 years. Before that, it was a group of physicians that did this. But when we look at these things, we look and say, there is an issue when you're using midazolam as a solo agent. Okay, midazolam is a benzodiazepine, and that is a medication that we use like it's similar to like a Valium that you use for a seizure. It is a GABA receptor agonist, and what that just means is one of the effects of it is it decreases your respiratory drive. So when you look at this and you start using that medication solely for every condition, when you give that to someone who has alcohol intoxication, alcohol is also a GABA agonist. So the combination of those two things together cause significant respiratory depression, meaning people will stop breathing or they can stop breathing, and it requires the paramedics to intervene to support them. It requires the hospitals to possibly put them on a ventilator. That is not a good, safe practice for patients. So when you're looking at, what is best for the patient, what is best for the provider is to give good medical care. It is not a true statement to say that midazolam is a best medication with no complications in every instance. So as the EMS medical director, when we look at our guidelines, we are responsible, and I'm responsible to draft and update the guidelines to represent best medical practice for those patients to choose the safer option for medications. And in this case, the overwhelming evidence and the gold standard of care in the metro area is that droperidol is the safer choice, particularly in those patients who are alcohol intoxicated, to lessen the risk of any kind of respiratory complication for them.
And you referenced the importance of following standard of care during your meeting in public safety in courts. What does that mean?
So standard of care is referring to, it's a medical terminology, but in medical law, it essentially means that you are practicing to the standard of what other physicians would be in your area. So when it is good to be able to meet the standard of care or exceed the standard of care. If you're doing something that is outside the standard and you have complications or you have something untoward happen, that is a risk, and that is not a good practice to be in. So you always want to try to meet that standard of care. Since every single metro agency in the Denver metro area all uses the same core set of protocols. This is the Denver Metro EMS protocols. They are developed by 24 emergency physicians with EMS training, and they've been in practice for decades now. And we continually update those. And so when we look at this, we are definitely not in line with what the standard should be, and we need to do this.
Okay. And why do paramedics have the ability to use sedative medications?
Okay. So the question is, why do we use sedatives in the EMS? Sedatives in EMS is about making sure that you can deliver appropriate medical care to your patient. So when you get to a patient, you're obligated, as part of a paramedic, you're obligated to offer care and render appropriate medical care, and that's just part of your job that you have. If a patient has decision-making capacity and you get there and you evaluate them and you offer them care and they don't want it, they can refuse. That's every patient's right to refuse that. In situations where there's significant ultramentation or they don't have that capacity to really understand the risks and benefits of what you're trying to do, you are obligated to provide medical care to the best of your ability. You have to identify and treat life-threatening conditions. If the patient is very, very combative or very aggressive, and you are unable to safely treat that patient, you can't evaluate him, you can't get vital signs, you can't give appropriate care, or you're going to get hurt in doing so, the use of a sedative would be an appropriate medical treatment. Obviously, things like verbal de-escalation are emphasized first. We try to find other ways to, get the patient into a state where we can give them appropriate care. But we want to make sure that we identify life-threatening conditions, treat them appropriately, and get patients to appropriate medical care.
Okay. And then by introducing droperidol, are you expanding who gets sedated?
No, the indications for when paramedics are using sedatives is the same as it was, 2 months ago as it is 2 months from now. It is solely when you have a patient who has a suspected or known life-threatening condition that you're trying to identify and treat, who has significant agitation or combativeness and doesn't have the decision-making capacity to refuse care, then that could be used. Sedative could be used when you need to use that to safely care for the patient. There's nothing about droperidol that is expanding the use of a sedative as far as saying that someone that knew would need to be sedated tomorrow that it was not today. It's about saying that if we know the cause of the agitation, or if it appears that likely alcohol intoxication is present or significant head injury, then the overwhelming evidence is that the droperidol is the preferred drug. much safer for the patient.
Anything else, doctor? Would you like to add at this time?
No, I mean, this has been a process that we have been working with the department for a long time, well over a year. There's been extensive engagement with everyone from the membership, the EMS providers. There's been in-person trainings with myself and open discussion forums for many months about this. This is something that we want to make sure that we are delivering appropriate care, and I firmly believe that what's safest for everyone, what's safest for the patient, what is safest for the EMS provider, is to make sure you're delivering the appropriate care. If we're intentionally trying to force them to use midazolam, which what we're saying is for particularly those patients who are alcohol intoxicated, we're specifically trying to get them to use a medication which the physicians are overwhelmingly saying that is not the best care for the patient and has increased risks. So that is not the best practice for the providers and paramedics of Aurora.
Questions of Dr. Hill?
Mayor.
I'm sorry, Councilmember Garland.
Thank you. Dr. Hill, so you said previously to a question you were asked that other EMS agencies in the metro area use droperidol. So for example, Denver, how long has Denver had droperidol in their EMS protocol?
Oh gosh, let's see. Well, droperidol was actually a complicated answer. So it actually was in use since the 80s. It actually was in use in Aurora in the 80s and 90s too. It was not made for about 15 years until about 2015, 2016 again, and then started being made again in this country. I couldn't tell you the exact year. The Metro protocols, I think, added them back in around 2018, I want to say. But it's been several years.
Okay, so in the last 4 years, let's say, what have you learned about droperidol that made it appropriate today but not appropriate 4 years ago?
So, first of all, when we were evaluating the treatment protocols, you look at what is the evidence of these things, and like I said, I've actually had these conversations for 2+ years because of the overwhelming concern from members from the department to make sure that we had the processes in place, that we had the state review panels in place, that we did those processes. We wanted to make sure we did that. So we have been ready to go with this from the medical directors for over a year. The department gave specific things they wanted to have in place, such as discussions with the membership, have in-person trainings. They wanted me to discuss this with the consent monitors, which we did, and they had their own independent review person evaluate this protocol and plan. And we have met all of those criteria, which is why we are implementing it now.
So you mentioned that it wasn't made for about 15 years, but you didn't mention why. In fact, wasn't it stopped being made because the FDA black label warning that it can cause heart and respiratory issues?
Yeah. So the black box warning for droperidol was specifically around the areas that were concerned with something called QT prolongation. When you actually delve into the research for what triggered the black box warning, it was at pretty high doses. We're talking 50 to 100 milligrams in most cases. And so they did extensive research. There was a series of papers that came out in 2015, ongoing medical literature research, which has shown that is overwhelmingly still a very safe and effective medication, particularly in the doses you're talking about, because we're not talking about the same doses. Doses in EMS are typically 5 milligrams. They're not 50 milligrams. That's 10 times the amount. So once it started being made again, once the overwhelming medical literature in the last 5 years has shown this is safe and appropriate, randomized controlled studies in both hospital and pre-hospital settings, it started to be made again. And hospitals have adopted it back in their systems again. EMS agencies have started to adopt it in their EMS protocols again, and that is why it is being used.
So was not ketamine previously in the EMS protocols, and similar statements were made about it as well, the safety of using it?
So these are not the same medications, okay? Ketamine is a completely different type of medication.
I understand that. That wasn't my question.
Okay, I guess I missed your question then.
Was it not said that ketamine was a safe drug to use when it was previously in the EMS protocol?
So ketamine is a drug that is used as a sedative. It's used in both hospital and EMS systems. The state task force which was run by the state, composed of multiple physicians from various medical specialties, including anesthesia, emergency medicine, and so on, their findings were that ketamine is a safe and appropriate drug for use in EMS when used appropriately for those conditions. And that was the findings of the state task force from last year.
And my last question, do you believe that 2 firefighters should be on trial for murder for administering ketamine?
No.
That's all my questions.
Further questions of Dr. Hill?
Mayor.
Councilmember Jaworski.
Yeah, Dr. Hill, you said that you've been working with the department for a little over a year on this. And I believe that to be true because I know that Chief Gray shot this down. And Chief Gray said, we're not introducing droperidol right now. And it's interesting to me, the timing of this, that Chief Gray leaves and immediately when he leaves, all of a sudden this comes back and this is being pushed back on our firefighters. And that's why I guess the union didn't really have time to even react to this because the last they knew, Chief Gray said, absolutely not, we're not doing this right now. So I believe you when you say that you've been working with the department for over a year, but can you please explain the timeline of this? Chief Gray shoots this down, he leaves. As soon as Chief Robnett becomes the interim, you reintroduce this and start pushing this back onto our firefighters?
Sure. So like I say, I worked very closely with the department about this process to make sure that the concerns that Chief Gray were done and addressed appropriately. When we went through the consent decree process last fall, it was asked for to make sure that the consent decree process was in place and we had vetted that through them before we introduced that medication. There was never any discussions with me after that from Chief Gray that there had to be any further timeline or delay of that process. So we vetted that process. We started having conversations with the representative from the union to the medical directors group in January. I had personal discussions with union leadership in, I believe it was March or April, as well as again in June. We had in-person trainings, 18 different sessions that I led personally with them, including all the members of Aurora Fire Rescue that came through there for a period of 18 different sessions in May to do this. This was vetted through the consent decree process starting in, I think, March or April. They went through their independent process. They consulted an independent medical director in a different state who said he had no concerns and this was appropriate. We asked what other measures they wanted us to do to, I guess, address their concerns. We went to the Citizens Advisory Council for the consent decree process, let them know what we were doing as an approach for this, and then we also went to the public safety and courts to let the city council know that we were also taking this approach. I was not made aware that Chief Gray was leaving until, I mean, basically whenever he announced it, which I think was like May or June or something. It was very, very short. The process of implementation had started 5 months earlier.
But so you acknowledge that Chief Gray had concerns with introducing this sedative.
He wanted to make sure we did it appropriately, and that they had the membership was trained appropriately. We had our processes in place, and yes, he definitely had concerns.
Okay, that's all for me right now.
Further questions of Dr. Hill?
Mayor.
I'm sorry, who is this?
Zavonic.
Councilmember Zavonic.
Yeah, Dr. Hill or frankly anybody from the department. So if this resolution, or I guess in this case now it's an ordinance passes, what are the options for our first responders when they interact with somebody who they would have typically administered a sedative, and how often does this happen?
So based on we did our 6-month review to the consent decree process. Submitted that. We averaged 13 times we used a sedative to manage a combative patient, 13 times per month over the previous 6 months of time. There was not a so that process was done in place there. The first part of your question was, so what was your option?
What are the current options? I guess so. A Versed, right? And that is there other options? I mean, how will they?
No, the only sedating medications that that would be used as a sedative that Aurora Fire Rescue has currently is midazolam, which as we said has significant risks associated with it in certain patient populations.
Is so with Versed or midazolam, how was it introduced as opposed to ketamine? What made it safer, and then what? And you now are suggesting that droperidol is even safer than that. Like, so talk to us about how and why this is different than ketamine.
So all these medications have a slightly different risk profile and how they work. I mean, there's not one medication that has zero side effects. There's not one medication that has every single indication it covers appropriately. Midazolam has been used for a very long time because it's a medication we also use for seizure management, in addition to for the use as a chemical sedative when needed. Prior to 2002, I'm sure droperidol was in place then, but that was long before my time. Haldol is also another medication that is sometimes used by EMS, and Haldol and droperidol are like very similar to each other. They're antipsychotics, so they work on the dopamine receptor in the brain. They don't work on the respiratory receptors or anything else. So they're all very different that way. Ketamine is a different type of medication. It's called a dissociative hypnotic. Works very differently, has different things like pain control properties. We use it a lot in hospitals daily for things like procedural sedations to perform procedures such as fracture reductions and things like that. So it's just a very different medication with a different property. I would never. Droperidol is not a substitute or replacement for ketamine. They don't treat the same thing.
Is droperidol or Versed a weight-based sedative the way that ketamine is, or how is it different?
No, they are. So ketamine, the way we had it listed was try to get the most appropriate dose. We had it listed as a weight-based. Droperidol is not that way. Neither is midazolam when used in this function. So we use a standardized dosing of 5 milligrams, repeated times 2 at the most.
And did the associate medical directors also agree with you, in your opinion, that droperidol is a safer sedative to use for our residents?
Yes, we have 4 different associate medical directors for the Aurora EMS system. They are in agreement with all of the Denver Metro EMS physicians, which is about 26. All agree that droperidol is a safe and effective medication for use in EMS systems.
And are sedatives used for any other purposes besides trying to get somebody under control currently?
I mean, not as you might use it as a seizure medication. So, like I say, if someone was having a seizure,
use what? Oh, midazolam.
Yeah, midazolam does stop seizures. Droperidol really, the only other indication and protocol for droperidol, is as a nausea vomiting medication. In hospitals, we use it for things like abdominal pain and migraines and some other things too. But primarily, it can be used as a second line agent for intractable vomiting. And then it has at a slightly higher dose, the 5 milligram dose, as an indication as a chemical sedative.
So I have a question. I guess this might be for Charlie or Travis. Given that even if this resolution or ordinance passes, there's still the opportunity to use Versed. Should we get rid of any potential sedative being used by the fire department in order to? Because it sounds like what I heard from the presentation is there was concern about the liability. It doesn't sound like the safetiness is in question as much as the potential liability, which I understand. And so, but the fact of the matter is you would still be using a sedative in Versed, which, as we're hearing from Dr. Hill and all 3 of our associate directors, is a less safe alternative than droperidol. So my question is, should we go further and get rid of all potential sedatives?
Thank you, Councilmember Zvonek. He gave that stat. Dr. Hill gave the stat that we've sedated patients on average 13 times a month. That would be Versed because we don't have any droperidol right now. Yep. And you can correct me if I'm wrong, but I don't think anybody has been arrested for that use or there's been any major incidents from that use. So clearly it's working. As far as should we go a step further, I don't think that's a question Local 1290 can answer. I think that's something the citizens of Aurora should answer, honestly. Do they want their paramedics sedating people in the city of Aurora?
Yeah. I'm wondering from a liability standpoint, because it sounds like what you're all concerned with is the liability, which I completely understand. I want to make sure that all of your members don't fear that, the consequences of doing their job. And right now they're still using the sedative, which you said is Versed. And yes, we haven't had any lawsuits yet, thank God. But as Dr. Hill said, it does repress the respiratory drive the way that ketamine did. And if we inject it in somebody who is intoxicated, there is a higher risk to that person, which would then lead to a higher risk for our firefighters. So my point is, if we're going to say we're going to put a 3-year ban on a safer sedative to stay with our current, does that not create the same liability for you all? And should we go a step further?
Council member, this is Charlie Richardson. Can you hear me?
Yes, sir.
Yeah, I certainly can't debate with a medical doctor, but
Here we are.
Yeah, and I've done social media, public internet research on droperidol, and I really encourage the council to go to the description of that drug in the Mayo Clinic website. Go to Mayo Clinic. It talks about droperidol right off the top. It says administer in a hospital setting. Get a cardiac readout before its administration. It's alcohol contraindicated. There's at least 40 contraindicated drugs that you should not combine droperidol with. Now, these paramedics are not in a hospital where you can have informed consent and monitor. In fact, if you look at the Mayo Clinic article, it says this drug should be used in the setting of a hospital. And so our paramedics are on the streets and in the homes. And again, they have been so traumatized by what happened to brothers Pete and Jeremy. They are so frightened. The city administration can order them to use it. The fire administration can order them to use it. Dr. Hill can order them to use it. And use your common sense. It's not happening. And also, we have a legal team. We have a team already in place because we know what's going to happen. The fire administration is going to try to discipline a firefighter for not, if, gosh forbid, this new drug goes online, they are going to try to discipline a firefighter for not using it. We've already got a team in place. We are going to fight that all the way. So please take this unnecessary new drug off the table. Thank you.
Do you not fear, Charlie, do you not fear that with continuing to administer Versed leaves you with the same legal exposure?
Well, here's the issue. The firefighters, and I'll just be very honest, they sit when they're not on a call in a fire station, and they have I've learned they have a tremendous communication system, and they talk a lot. And Versed, because it has not historically ever caused a problem, the membership, and again, they're not medical doctors, the membership is comfortable with something they've been using for years and years and years and years. And it has not been associated with 11 counts, felonies, and sentence enhancers.
Has any other sedative besides ketamine?
Has what?
Has any other sedative besides
This is the first time firefighters have been criminally charged for doing their job.
Okay, so ketamine. So that what you just said about Versed is true of every other sedative except for ketamine.
Correct.
Dr. Hill, has there been any instance where Versed has negatively impacted somebody it's been used on?
Yes. With all due respect, on a couple different issues here. One, the issue of, there's been no incidents or problems. It's just not a true statement. When you look at when you review medical care, you look at things, it's not just the pre-hospital care you're looking at into the hospital and everything that happens to that patient as a result of that. The onset of action of midazolam is upwards of 18 to 20 minutes sometimes. And sometimes, the transport times are 10 minutes. So they might give a medication like that, but they haven't had a peak onset until they're in the emergency department. I personally have received patients like this in the last 9 years of working in the Aurora EMS system, where patients have had to be intubated and put on ventilators after receiving midazolam. Not just from Aurora, but that's from other EMS systems too. So it's just not a true statement that there's no safety issues related to midazolam use. As far as a couple other things, there's a question about disciplinary action. I find that to be a disingenuous statement for myself, because we practice what's called a just culture model. It's focused on learning, quality improvement, and I have had many of these reviews done over the last 5+ years. This is the kind of gold standard we use in the healthcare system to make sure that you identify issues, you learn from these issues, you address the issues. It's about a joint accountability. I'm not disciplining anybody in that way, and there's been no incidents of me trying to discipline somebody for trying to follow appropriate medical care and delivering appropriate medical care to somebody.
Further questions of Dr. Hill?
Mayor.
Councilmember O'Connell.
Thank you, sir. And thank you, Dr. Hill, for being here with us. So my question for you, earlier you mentioned concerns about combative patients. And I just want to ask you, do you believe that that's a legitimate reason to sedate a patient?
Yes. Well, if a patient is combative, okay, and you suspect this patient has a legitimate medical condition that requires treatment, you want to try to deliver care to that patient the best you can, because you don't know what the cause of that combativeness is. Okay, it's very easy to say, like, hey, if we do nothing, this will all be fine, but that's not the case. I just received a patient the other night, and I'm not going to get into enough to really identify the patient, but I received a patient the other night that was hit by a motor vehicle. Okay, had serious head injuries, spinal fractures, was altered, combative, fighting us the entire time as we're trying to treat this patient. Yes, we needed sedation for that patient because they had an unstable spinal column, and so by not providing appropriate medical care, we could have let the patient die. Okay, we could have let them permanently paralyzed. So you want to be able to try to render appropriate medical care. You don't know if they're septic. You don't know if they have low oxygen levels. You don't know if their blood sugar is low. You don't know. And so you want to do it. If you can do it just by, some gentle manually holding somebody down and check these things and roll these things out, fine. Okay. But I want to make sure that we are identifying life-threatening conditions and resuscitating those patients that need those kind of conditions. Because I don't want us to, have someone say, we are not providing appropriate medical care to our patients, and that someone that was critically injured or hurt, that we did not try to render aid.
Okay.
Further questions of Dr. Hill?
Mayor, can I continue?
Please proceed.
Thank you, sir. So I just want to point out that I think the key point of contention here, especially within the context of, our two medics who are facing, potential jail time here, is that this was done during the scope and course of law enforcement activity. And I think that's why this has received so much scrutiny, specifically ketamine. So in those circumstances, as you witnessed with the McLean incident, do you believe that that is a legitimate use of a sedative?
You should never, I won't speak to a specific case, you should never use a chemical sedative for a law enforcement purpose. It is a medical treatment to treat a medical patient for a medical reason. It is never to be encouraged for or used for any other reason, ever.
Okay. Mayor, may I continue?
Please proceed.
All right, thank you. And this is for Aurora Fire Rescue and Charlie. Do the procedures and protocols for Aurora Fire Rescue currently prohibit what Dr. Hill just described?
Can you repeat that? Sorry. This is Travis.
Sure. So basically within the scope and course of law enforcement activity, do we have a prohibition for Aurora Fire Rescue to effectively administer sedatives to make someone easier or more compliant?
Councilmember Marcano, Charlie here. One of the good things that came out of that very tragic incident was a consent decree driven wall now And we support that 1,000%. And yes, honestly, that was a cultural issue where the police might say, hey, we're having trouble dealing with this person. Can you knock them out for us? I'm being very candid. The consent decree says that should never happen again. It places a tremendous burden on the paramedics now. The police are supposed to step away, and the paramedics now, and they can't instruct the paramedics to do anything. The paramedics make a completely independent, medically based judgment. Did I answer your question?
Yes, sir, you did. And I'm very happy to hear that because that's where I was leading with one of my lines of questioning. So thank you. So I have another follow-up then. Seeing that that wall does exist, which again, I'm very happy to hear. This question is for my colleagues who are sponsoring this resolution, I guess now ordinance. Based off of what you've heard, is your primary concern, or do you feel that your primary concern or the concern that you've heard from our firefighters addressed to some extent? Because my concern here is that we would inadvertently prohibit medication that could be used outside of a law enforcement action, which to the best of my knowledge, and please correct me if I'm wrong, is not the impetus for both the jail time that our medics are facing, but nor has really been a major issue for our department in the past.
I guess I'll go, Mayor.
Please.
So my answer to that is no. I'm still not hearing. So now if they're going to have droperidol and Versed on their trucks, and they decide to use Versed over droperidol, their idea is that they're actually going to be punished now at this point for not using droperidol. And I don't hear anything from Jim Twombly. I don't hear anything from Jason Batchelor. I don't hear anything from Dr. Hill assuring these firefighters that if they still continue to use Versed or no sedative at all and get patients to hospitals, for something to be administered, that they're not going to be in trouble. I don't hear that assurity. I don't know, Councilmember Gardner, if you want to speak to that too, but
Mayor.
I feel very strongly.
I'd like to speak to that, Mayor.
Councilor,
Manager.
I'm sorry, Mr. Twombly.
I think it was stated before that the city manager or the fire chief can stop or punish something that's a medical procedure. And as Dr. Hill explained, the paramedics operate under his license. He does the quality control. I'm not a doctor. I can't punish or direct the firefighters and paramedics to perform or not perform medical procedures. And neither can the fire chief.
Further questions?
Mayor,
I'm sorry.
it's Councilmember Lawson. Oh, Councilmember Medina, go first.
Councilmember Lawson.
Go ahead.
Okay. Dr. Hill, I have a question. There's something that you stated here in when you were talking about droperidol. You said that and I know all sedatives have a risk population. So in this particular case, what is the risk population for this? And then part B to that question, if you know that it's a risk to a certain population or people, then why would it be administered, or why would it still be administered if there was some type of combative nature going on with that particular patient or person?
So is your question specifically about the contraindications to droperidol?
You stated that there are certain risk populations that would be impacted by droperidol, by this drug. So the question that I'm asking you, if you know that if there's a risk population, just like it probably was maybe with ketamine, but if there's a risk population, would someone still, if they're in a combative mode, would they still administer this drug if it's impacting the risk population that you're stating that could be impacted mostly by this drug?
So if you know when you're evaluating the patient, there's a contraindication to the medication it listed in the protocol, then you would try not to use that medication. So with droperidol, it specifically is preferred for intoxicated patients, patients who have combative head injuries, is the primary. The patients who have a sympathomimetic toxidrome, which is like more like the meth rage or something along those lines, typically we use midazolam for it. So if you know that's what you're dealing with, typically patients that are more sensitive to medications, like the elderly patients, you would not. We try to not use it, or if we have to, we use like a half the dosage of it. We don't really use it in pediatrics typically as the issue. So if you know there's a contraindication when you're evaluating the patient, then you would not want to use it. But you're looking for what is the indication and what is the best medication for that condition that you have.
Mayor,
And
can I do a
without doubt, they always have the ability. I mean, in situations when there's a concern or there's like some kind of clinical uncertainty, every single medic can call a base contact physician and get expert physician consultation on that issue. Always.
Okay, I understand that, but sometimes when you don't know what allergic reactions people may have to certain medications, so you're kind of examining, I'm not a doctor, and of course you want the best care for the patient. But if you know that there's a certain risk population, that's just kind of what I'm getting stuck with this, then why would I guess other things you're stating could be used based on the condition of that patient. So if a patient is combative, from whatever reason, and you see that they're in a risk population, then it could be the decision of a doctor or whatever you're looking at that point, because you're trying to, calm the person down to decide what is the best medication, and it may not be this one. Is that correct?
Yeah, you always when you're working with very limited information, you always try to make the best medical judgment you have. In emergency medicine, that's the same process we have. When someone comes in, we don't always have their medical file in front of us. We don't always know these things. So you choose medications that have, the best medical evidence for that process. If you determine later that they have an allergy, then, we do the best we can, but we always try to make sure that you do it in a way that is a very narrow indication, that using good clinical judgment and using it for a very specific reason. I mean, someone might have an allergy to, epinephrine or Benadryl, but if you find someone on anaphylaxis, you're going to go up and give them an epinephrine pen or a Benadryl shot because you're acting in good faith to try to help that person. You may not know that later until they have an allergy to Benadryl, but you're still trying to help that patient to the best of your ability.
And Mayor, just my final question, what are the risk populations that are associated with this drug that you were referencing in your statement?
Are you talking about the risks of like who the medication is
you
for?
said that there are certain risk populations. So can you tell me with this drug, what are those risk populations? Based on, I haven't read the Mayo Clinic, I haven't read about what are those populations that are susceptible to having certain issues with this drug?
So if we know they have a very long QT syndrome, we would not use this kind of a medication. So that's a QT interval over 500 milliseconds typically. If we don't typically use it in pediatrics. In elderly, we use it in caution just because elderly patients are more sensitive to these types of medications. It is not contraindicated in an intoxicated patient. It's actually a primary indication for that. That's in the national scope of practice by something called NASEMSO and the national scope of national practice for the paramedicine for their indications for that medication.
Okay, thank you.
Thank you. Further questions of Dr. Hill?
Mayor, Councilmember Medina.
Councilmember Medina.
Thank you, sir. Dr. Hill, I'm just curious, do you have protocols for combative patients that you utilize to restrain them to the pram?
Yeah, there's a restraint process. So restraints are authorized when someone is showing physical aggression or combativeness to the crew to make sure that the crews aren't hurt to the best of their ability, and also that we try not to physically hold someone down with our hands. That tends to increase risk of injury. Sometimes that's always a part of a process when someone is very aggressive and sedated, or regressive and combative. Sometimes that is not enough. I mean, if someone's in restraints and we can use verbal de-escalation and a combination of restraints and get compliance to get put proper medical care on, give them appropriate medications, evaluate, rule those things out, then they stop. They don't continue to use a sedative at that point. There are patients that even despite the use of restraints, they are still flying off the pram, rocking the bed, grabbing a hold of staff members. We've had multiple staff members in the last 4 months been grabbed by patients, pulled down, punched in the face while in restraints. They managed to get a hold of them with their hands.
Okay. Now, I'm just curious because I mean, having been in this profession, number one, I know that there's restraints, and then on top of that, you got a series of belts as well that you can tie people basically from top to bottom, and that's standard protocol. If someone's got a neck injury, put them on a board, strap them down. So I was just curious about that. The other question I have, sir, is you had mentioned something about that paramedics have access to a medical advisor, I guess, or a doctor or somebody on the line. Is that something that's always available at 24/7? Is there always somebody that they can access that they can give you maybe the vitals, that give you the situation so that they can get a feedback so they can make sure that they're doing, their prudent judgment and getting that backup?
Yes, 24 hours a day, 7 days a week. They always have the ability to contact the emergency physicians and the receiving hospitals in the local Aurora area to receive that consultation. I've also extended in situations that are more dynamic and hard to explain exactly. Every battalion chief and supervisor from Falk has my cell phone as well, and they can call me directly as well if they can navigate the situation.
Right. Thank you, sir.
Further questions of Dr. Hill?
Mayor Sundberg.
Councilmember Sundberg.
So I'm learning here, and I'm trying to formulate an objective observation, and I understand how the firefighters are concerned by this unprecedented situation that they're in, and I understand also the need to sedate someone to protect everyone involved, including themselves. My first question for Dr. Hill would be, my Dazalan and Versed, are those the same? I've heard them. They are the same, and they're used currently. Now, when you've gone through this orientation phase thus far to get to where we are now with Droperidol, you've held some training, some orientations. Have you encountered some veteran firefighters? I mean, there's people that have been around for 30 years doing this job. They're darn good at it. They've probably been around so long, they've used Versed, ketamine, and Droperidol, perhaps. Are you encountering veteran, experienced, expert paramedic firefighters out there that are expressing an opinion to you about what they'd like to use based on their field experience?
So every veteran paramedic that I've talked to that has been around long enough to use Droperidol, which was prior to 2002, has expressed support of the use of Droperidol. It is a better medication by far.
Okay, in Aurora Fire Department, you've experienced.
Yes.
Okay, thank you for that. And then this next question, my last question, could be for Councilmember Gardner. Why no ban of our current sedative, Versed? Has that been a concern, just to wipe out? And this sort of piggybacks on Councilmember Zavanic's question earlier, I suppose. But why no effort to wipe out any sedative chemical from our toolbox?
Mayor.
Please proceed.
Yeah, I would certainly be open to that conversation. The reason why this was done the way it was because of the timeliness required because of the introduction of Droperidol. But certainly, I would be supportive of an effort to remove chemical sedatives completely. I think there are civil liberties concerns with administering a sedative on someone against their will, and other concerns. And I don't want another firefighter on trial for murder. So yeah, I would certainly be open to that conversation and would consider what you and Councilmember Zavanik proposed as a friendly amendment. But I think the reason this was done this way is because of the time required with the introduction of Droperidol coming.
Thank you.
If I could ask Dr. Hill a question, and that is, doesn't it put the city at liability if in fact we don't make a sedative available and we're simply in effect not treating a patient maybe who has excited delirium and they're very combative and so we're in effect we're violating the standard of care. So does that put the city at some risk in terms of liability? Dr. Hill?
I think there's two issues there. Yes, I think there is significant liability involved in that practice for two reasons. One, because you're specifically violating the standard of care and best medical practice for that area. So patients who are, injured in that process, crew members that might be injured in a call where they're not using the proper medications, that increases your risk liability. I'm not a risk legal expert, but yes. The other part of it is the liability is that these are medical protocols issued by a licensed physician, and that's what they require. These are standing physician orders on how to treat a patient. So when you're saying that you're supplementing the, you're trying to say that we're not going to follow the physician's orders on how to treat a patient, I think there's significant liability on the scope of practice of medicine and state law on that. Once again, I'm not a legal expert on that, but that's my understanding, and that might be a good question for legal counsel on that.
Is there someone from the city attorney's office that can comment on that?
Mayor, it's Pete Schulte, Public Safety Client Manager. There are some legal implications to that course of action. There are Dr. Hill did state some situations where that can occur that could cause liability for the city. Each situation is going to be looked at by the facts. But one of the things that we have seen and that we are concerned about is if there is a patient who is medically combative and the medical protocol by Dr. Hill does state for medical purposes only that one of these sedatives should be given. If it's somebody who's having an uncontrolled medical condition and they're potentially causing injury not intentionally to the paramedic, what does the police department do? Right? The police department's not going to get involved unless there's a criminal act going on that's against the paramedics. So that's the other concern is if to have these available to be able to control patients that are not able to control themselves for a medical reason. Again, we're talking about, and again, and Dr. I don't know if this has been clear, but we're talking about chemical sedatives used as a chemical restraint. I think there's a distinction there that I haven't heard. I just want to make sure that we're aware of this, that chemical sedatives are used for medical purposes all the time. It's when they're used as a chemical restraint is what I think we're talking about.
Mayor Zvonek, can I ask?
Councilmember Zvonek.
Yeah, so this is a follow-up, maybe to Dr. maybe to Pete. So if we don't, let's say that we don't administer any sedative, right? We make that, that's the policy of Aurora Fire and Rescue's paramedics. Does that responsibility then fall to Falck? And in which case, I know we have medical control, and is that something that during this ban, we should switch to make sure that, because at the end of the day, I think we have to make sure that our residents are also the one that we're considering them. And if they need to be restrained for a medical purpose, again, not for a law enforcement purpose, but for a medical purpose. And we are saying we're going to have a policy of no sedatives. So it's going to be physical restraint. And so this is my follow-up question to my first part, is there any liability created in 217 with physical restraint for our first responders?
I'll take that, Councilmember Zvonek. So yes, the issue with we having paramedics on the engines, right, is because Falck can take longer to get there than our fire department can to respond to calls. So if there's an expectation of whatever the reasonable standard of care, as Dr. Hill was talking about, and because of our ordinance or whatever it is that says we cannot use these chemical sedatives for a medical purpose, and somebody dies or somebody something bad happens, again, depends, it's all fact specific. I don't want to talk about worst case scenario, but yes, it does increase our opportunity to get sued in a situation like that.
And then are there implications from 217 related to physical restraint and harm with first responders?
Yes. So if there is no ability to restrain somebody who is dealing with our fire department under Senate Bill 217, yes, having to use physical force in that regard with no criminal activity happening could put our police officers at risk for criminal or civil liability.
Further questions with Dr. Hill or staff? Councilmember Coombs.
So I just have a little bit of confusion about the medical questions here. There was a statement by Mr. Richardson that there's a contraindication for alcohol for droperidol. And then Dr. Hill is saying that that's the use case for droperidol. for our paramedics. So I'm just confused. Is there any alcohol contraindication associated with droperidol, for one? And for two, Mr. Richardson stated there were a bunch of other medical contraindications, both for medications as well as medical conditions, that it might be difficult to assess or know. So is there additional risk to the patient of using this medication when we're not able to assess for the use of some of those other medications and other medical risks?
So if you look at almost any medication, they all list alcohol as a potential, aggravating issue. Midazolam very significantly has an alcohol list of mixing Valium and alcohol, or midazolam and alcohol has serious, associated side effects with that, or known adverse effects. If you're comparing the two together, okay, the overwhelming opinion of every emergency physician that practices emergency medicine and EMS practice is that if you're comparing the two together, droperidol has a better safety profile than midazolam would be in those patients.
Okay, and what about the other medical risks? The other medical contraindications, either for medications or medical conditions, for droperidol? Is there a risk of liability associated with difficulty assessing those risk factors?
No, so like I say, you're always acting when you're acting under implied consent, meaning the patient is unable to consent due to the medical condition they have ultramentation. You're acting in good faith to try to stabilize that patient to your best of your ability. If you give a medication and they have a reaction to it, as long as you are acting in good intentions and faith, then that is appropriate and that is defensible medicine. The contraindications for droperidol are rare. I mean, a long QT interval is not a common condition to have that we see that all the time. So when you're weighing a risk benefit of, I have a patient who's clearly intoxicated and has serious injuries I'm suspecting, or I suspect a serious medical condition, and I need to get control of that, versus they may have a very rare condition that we cannot properly assess for, because the only way to get a QT interval is to put a 12-lead EKG on somebody and have them hold completely still. You can't do that in someone who's combative. So you act in good faith and use this medication, which is why all the studies that we've done show that the risk at the dosing for EMS, the risk of a cardiac event is extremely, extremely low. And it is much safer to use than the other medication options we have available.
Thank you.
Further
Mayor.
question, Dr. Hill, I'm sorry.
Mayor Marcano.
Councilmember Marcano.
Thank you, sir. So Dr. Hill, earlier the mayor asked you a question about excited delirium. And I just have to ask you, do you recognize that as a legitimate diagnosis?
The excited delirium was a diagnosis that was developed in emergency medicine from, I want to say, like 2009. After kind of a deep review, national panels, we decided to abandon that term completely. It was turned into a term that was used too much by a law enforcement practice. It is the correct terminology now which is in line with more of the psychiatric diagnosis manual for psychosis, is more of a hyperactive delirium patient with severe agitation.
Okay. And would you, again, would you view that as a legitimate use for a sedative?
Yes, if they have hyperactive delirium, that is a medical emergency. This is someone who's like incredibly sick, metabolic acidosis, risk of severe cardiac arrhythmias. You want to evaluate the cause of that, and that's why if you look at the medical literature from between 2000 and 2010, that's kind of how emergency medicine came to realize, is they were trying to prevent in custody deaths. Okay, and when we have patients who are in this kind of state, when you put them prone, that's very bad. And so we want to get them off the prone, on the side, treat them medically as a patient, not as someone who's had a crime. This is a patient we're trying to treat.
Okay, so to me that sounds like a repackaging of some of the key components of excited delirium, which was tossed out, as you mentioned, by the AMA and others as a junk diagnosis. So What's the purpose of this new term then? Because it sounds like you're addressing the same condition.
Well, they're slightly different. It's a different way of recognizing a phenomena that we have of someone who is highly combative, hyperadrenergic. They're very ramped up, violent, combative in those ways. That is not unique. The droperidol really has nothing to do with that. The impetus for putting that in has nothing to do with hyperactive delirium. The impetus is that when you're having patients who are intoxicated and we're already using this, we're already using midazolam in these patients, is that we are inducing potential harm and risk to them. So we need to find a better alternative.
Okay. This is for Chief Robnett and the city manager. Are either of you aware for Aurora Fire Rescue getting sued or facing criminal liability for strictly medical application of sedatives, despite the implied consent that Dr. Hill mentioned earlier?
I'm sorry, would you restate the question or say it
Sure,
again?
Chief. Basically, are you or City Manager Twombly aware of Aurora Fire Rescue medics or personnel getting sued or facing any criminal liability for strictly medical application of sedatives under the implied consent that Dr. Hill mentioned earlier?
Not that I'm aware of, sir.
Nor me.
All right. So this last question then I guess is back to the sponsors. Would you consider amending this to be a chemical restraint ban as opposed to a blanket sedative ban?
Yes.
Yes.
Wonderful. Thank you both.
Further questions, discussion?
Mayor.
Councilmember Jernsky.
So I have a whole lot here. Dr. Hill, when was ketamine put into use in Aurora Fire?
I want to say it was 2018. Yeah, it was a 3-year process in 2018.
2018, and it was banned when?
It was the spring of. Sorry, COVID's kind of messed up my brain here a little bit as far as the timelines of things. It was, I want to say, fall of 2020, maybe.
So it was roughly in use for 2 years in Aurora Fire, right?
About a year and a half, because we didn't implement it till like mid-year, so it was about a year and a half.
Perfect. Year and a half, even better. And how long? When was Versed put into use in Aurora Fire?
It predates my time.
And you've been with the city how long?
5.5 years.
So Versed is certainly something that our paramedic firefighters know. I mean, it obviously predates you. It's still in use. Ketamine was in use for 1.5 years, and someone died. And we have 2 firefighters on trial for murder. So I think what this goes back to, the firefighters aren't saying no, they're saying not right now. Can we please have this conversation later? That's all they're saying. If we want to go the route to ban all chemical sedatives, then that's another conversation. But the conversation right now is that we have 2 firefighters on trial for murder. And Versed is still on their trucks, and it is something that has been around for years. And since 2020, since ketamine has been out of use, they've been using it when necessary. And again, this isn't an all the time thing. We don't have firefighters running around just injecting people daily. But when they've had to use it, they have it. And we haven't had any issues. We have not had any issues for the 2 years. We have not had an additional sedative longer than we had ketamine in this city. And there have been no issues, 0 issues. The second thing I want to say here to Councilmember Sundberg, there's actually been 2 firefighters that have called me and said that, given their regards on droperidol. But I come to find out that one that I spoke to just this morning that called me is a field training firefighter that works very closely with Dr. Hill. So I want to point that out. And actually, when I had a conversation with this firefighter, and I told him about conversations I'd had with other veteran firefighters, and that this conversation isn't they're not against droperidol you know, in some uses or whatever uses, they're just against having any conversation of introducing any new drug right now while two of their brothers are up for murder. And when I spoke to the one that called me this morning, a 20+ year veteran, and I named some other firefighters that I had spoken to personally, other 20+ year veterans, his whole demeanor changed. And he said, ma'am, I can't argue with that. He said, I have personally not missed one court appearance for my brothers, Pete and Jeremy, and I want them to come home. So I understand my colleagues' concerns. And with that, I know that whatever decision made tonight will be made in the best interest of the rest of my department. So I also wanted to address that. And Dr. Hill, you said as long as they're acting in good faith. As long as they're acting in good faith, that's appropriate and defensible medicine. Are you currently on the defense's witness list for Pete and Jeremy?
I have not received any kind of subpoenas, but I'm sure I will.
Okay, and you would be willing to go, you would answer that subpoena to defend Pete and Jeremy as appropriate and defensible medicine? In your words, that's your words, appropriate and defensible medicine.
Yes, I do not believe that Pete and Jeremy should be on trial.
Okay. Do you at all, Dr. Hill, understand why? I mean, if you yourself don't believe that Pete and Jeremy should be on trial, do you yourself understand why 400 members of Aurora Fire are terrified? Do you understand this at all? They're not against you. They're not against necessarily Dreperidol. They are terrified about what has happened and seeing two of their brothers, who you agree should not even be on trial for murder. Do you understand that at all? That is the basis of their concern here?
Yes, ma'am. I was a firefighter for a long time. Okay. I understand the fire service very well. Okay. I was a paramedic for many years before I became a physician. So, yes, I understand all these issues. When you're looking at what is appropriate, you know, when you say that there's no issues, the problem I've said several times tonight is that when you perform something and you put someone in the ICU on a ventilator, or you do something, that is serious risk of patient harm. Okay. And so I don't know, we always want to say the guiding principle of when we make our decision should always be what is appropriate for the patient. So if I have a medication which has a not insignificant risk profile, and I have another one which is infinitely safer, to me, those are the same thing. You want what's the thing for the better for the patient, because if the patient has a better outcome, that is safer for the paramedic.
Sure. And to Councilmember Lawson's comments talking about, you know, if our firefighters, if our paramedics don't know someone's medical condition, and you know this drug is issued as a chemical restraint, then what happens to them? Is that still appropriate and defensible medicine? Do you have the magic wand, Dr. Hill, to prevent another firefighter from going on trial for murder?
No, I do not control law enforcement or the AG's office or the district attorney's office.
Sure. So if they don't know someone's medical condition and this is a chaotic situation, and you're saying that they can call and they can get a physician on the phone, and which, by the way, maybe that should just be in your protocol, that if this drug is to be administered, then they need to call the receiving hospital before they administer the drug. I mean, maybe we talk about revamping your protocol if you're open to that conversation. But if they don't know someone's medical condition, the very same reasons why maybe Elijah McClain was wearing a hoodie and why he was dressed the way that he was in the dead of summer, if they don't know someone's medical condition and they administer this drug and it has an adverse effect and it kills somebody, you're saying that's appropriate and defensible medicine, that they are acting in good faith, but they could still end up on trial for murder. And the fact that these conversations are happening while we have two firefighters up on 11 charges, it's almost inhumane. It's heartless to me. That's how I see this. And I feel like our employees, our city employees, our firefighters are not being listened to. They're not being listened to. They have 11 charges. The police have 3. So absolutely, they are terrified. And I understand you used to be a firefighter, I understand that, but in where you sit right now, you will not face murder charges, sir. You will not face murder charges. These firefighters will. If they are acting in good faith and don't know someone's medical condition and they administer this, I mean, these are unprecedented times. These are unprecedented times to see 2 firefighters up for murder. And the fact that we are having this conversation to introduce a new drug that was only in use for 1.5 years in this city, it hasn't been in use for 2 years, and we've had no issues since. We have a drug, Versed, that has been on fire trucks for years, and we have not had one issue. It's what they know. It's what they've grown accustomed to, what they've gotten comfortable with, and there have been no issues in the past 2 years not having ketamine in play. So again, I don't understand. I know that Chief Gray had very serious concerns about introducing this, and I don't understand why we're having this conversation. You said earlier that 4 associate medical directors were also consulted on this, but I'm going to go out on a limb here. I'll go ahead and ask you. I'm sure those 4 associate medical directors also said that ketamine was safe at one point.
We've had different medical directors. Ketamine was used through most of the Denver metro area by most of the EMS physicians. As I said, the state advisory task force on that medication, which reviewed it, still says it is appropriate for use in EMS as an appropriate medication.
Yeah. Dr. Hill, if I could add in, we had hired outside experts to review the incident and the outside physician investigating the Elijah McLean incident that was hired by the city or by the city manager did in fact affirm that she felt that the drug was safe.
Mayor Sundberg?
Councilmember Sundberg.
Actually, I'm sorry, I wasn't done.
Okay.
I would like Charlie Richardson to respond to some of this about liability. I know that you have a law background, and I know that you also, fire has a team of attorneys. So I would like for Charlie Richardson, if he's still on here, to respond to liability.
Can you hear me?
Yes.
The city attorney's office knows that we have sovereign immunity for this liability that keeps being thrown around. The city attorney's office knows it's not one of the 6 exceptions to the city's sovereign immunity. It is a scare tactic. And I ask council, get permission of City Manager Twombly and the Chief, Rob Nett, go to a fire station, have dinner, and tell the firefighters, oh, did you know that the city could be liable if you don't inject someone? But if you do inject someone in goodwill, and I'll address that in a second, you could spend decades in prison. And that there seems to be a disassociative reality going on here between what the firefighters are feeling now and this high level discussion. And I'm glad to hear Dr. Hill say that brothers Jeremy and Pete, I don't hug people often, but I think I hug both of them. What do you think their mindset was when they gave Mr. McLean that shot? Let's just be real candid. They were not trying to murder him. They were not trying to cause any physical harm. Of course, it was goodwill, 1,000%. They saw somebody struggling. They thought he would be better off if he could calm down. And I'm getting a little emotional here, but that's just the way it is. There's no liability. That's being tossed out there to scare council.
Mayor Sundberg, Daniel.
Councilmember Sundberg, I think I'm gonna get a sense of the council fairly soon.
May I propose an alteration that may be amenable to most, perhaps? Very briefly, there's a lot of great points being made across the board here, and I do think the timing is bad. I do see Reparadol with the argument and talking to other people that it is perhaps more beneficial than Versed, would the sponsors of this resolution be amenable to amending it to 18 months or 2 years instead of 3?
I'm fine with 2 years, and we can review it in 2 years.
Yeah, it doesn't matter. That's not the point of it, is the length of the moratorium. So yeah, 2 years is fine.
Okay. For further discussion, then I'm gonna get a sense of the council.
Mayor, if I could.
Councilmember Zvonic, the last word.
Yeah, so this is the last point, and it's just more of maybe a suggestion, because I get the liability concern, which is why I don't actually think we're addressing it. We would still be using Versed, which is according to every medical doctor that we've heard from, which is one, but there's been, I think we got a letter earlier from a bunch of others, that Versed is less safe. So we're going to continue to use one, which I think does not eliminate the liability issue. So my suggestion would be, if we want to address liability, and I still believe we should allow droperidol and Versed to be in the toolbox and give our paramedics all of the tools available, can we have a policy and have this be a directive to the city manager and to the department to say that anytime a sedative is being used, that it becomes a call-in instead of a standing order? That gives our first responders an extra layer of protection, because at any time they have to use a sedative for the purpose of dealing with a combative person, they'd have to call in and they'd have to determine whether it be Versed or droperidol based on the information that they have available. That actually does something, because I think just banning it's great theater, but I don't actually think it's going to give the liability coverage that we're looking for.
Councilmember Gardner.
I mean, I don't think that's a realistic expectation when, there's an emergency situation happening on the side of the road or wherever it is in the kind of the heat of the moment. I don't know that that's a realistic expectation. I certainly would be open to having that as a separate conversation on a separate item. After talking to firefighters and police officers and other emergency medical personnel about that specifically, because I don't have, the expertise to weigh in on whether or not that would be an appropriate use of their time in an emergency situation. And so my initial answer would be, let's have that conversation separately and not because it really isn't necessarily related to this item.
Dr. Hill, I wonder if you could comment on that, please.
So there is less liability for a paramedic if they call and get expert physician consultation, because then that doctor has directly given them an order of what medication to use. That is true. I have actually had this conversation with Chief Gray, with Chief Robnett. I have made that offer, including to members of the department. You have to have a caveat for exactly what you were describing, which is there are times when, there is imminent physical injury going on, where there's imminent injury occurring, fight going on. In those situations, it is not possible or practical to call in and get a doctor on the phone. There are times when you can do that, when the acuity is less. So I have said that I would be supportive of a approach like that, where you have a caveat for extreme exigent circumstances where there's imminent physical injury or risk going on, and require that they really completely document those calls. As I said, these are all reviewed very carefully and submitted, so I'd be fine with that approach. I think that to ignore the situation of saying that they're already giving midazolam and we are posing patients at increased risk, this resolution does not address that issue. This medication is specifically being proposed because we are causing increased risk to our firefighters and to our patients. Their interests are the same, is to make sure that the patient does well. That is the same.
Is there anyone who objects to moving 5C forward? Mayor objects.
I object.
Mayor, I just want clarification that it's with a 2-year moratorium down from 3 and a prohibition on chemical restraints.
That's correct.
All right, great. No objection from me.
A complete prohibition on chemical restraints, just for clarification, I'm sorry.
Yes.
That's what we're looking at going forward here.
Yes.
Okay, right now, Mayor, Councilmember Zavonic, object, is there further objection?
Sunberg.
Sunberg. Further objection? Further objection? Seeing no further objection, let me just ask in the affirmative, of support.
Marcano.
Lawson.
Coombs,
Rescue.
Marcano,
Medina.
Rescue,
Lawson.
Agreement. Awesome. Let's see, I've got Councilmembers Coombs, Marcano, Jerinsky, Medina, Lawson. Who else?
Gardner.
Gardner.
Okay, very well. Majority having arisen in support. Item number 5C will move forward to the floor. Item number 3A. Resolution approving the mutual aid agreement between Aurora Fire Rescue and South Adams County Fire Protection District. Rod Weber, Deputy Chief of Operations.
So I'm here for Rod this evening. This is basically what happened with South Adams acquired some additions to their district that was formerly held by Sable Altura. It became advantageous for us to work together for fire suppression only. So if the areas outlined in Aurora had a structure fire, they would send a unit, and vice versa in the unincorporated areas that they have acquired. If the structure fire exists, we would send a unit.
Questions on item number 3A? Seeing none, is there objection to moving item number 3A forward? Seeing none, item number 3A will move forward. Item number 3B, an intergovernmental agreement regarding funding of major drainage way planning for 4 square mile outfall systems plan. Sorvine Narinda. I'm saying that right. Planning and Engineering Services Manager.
Good evening, Council. Good evening, Mayor. My name is Suvin Yarenda, and what you have before you is a proposed IGA with the Mile High District, and this is for us to study this 4 square mile drainage area. And as I'll show you on the next page, this this IGA, I mean, the drainage area is a sub basin to the Cherry Creek Cherry Creek drainage basin, and it's really located roughly by the Cherry Creek Reservoir, spanning north west up to roughly Mississippi. And an outfall systems plan really is a study where we look at the entire storm system that includes all the piping, detention ponds, retention ponds, and everything that is required to convey the flows, the stormwater flows into the main stem, into the channel main stem. And this study was requested by Denver, and we are participating in this study. So if you go on to the next page, you will see that Aurora, if we go to the next slide, Aurora only is only contributing like 5% of the flows. So as a result, we are really contributing 5% of the costs, 5% of the 50%, because the district contributes 50%. That's why they're at 100,000, and then Semswa and Denver each at 45,000, and Aurora at 10,000. So, are you willing to take this to the main council?
Questions of staff? Seeing none, is there any objection to moving item number 3B forward? Seeing no objection, item number 3B will move forward. Item number 3C, define catalytic converters as secondhand property. Councilmember Gardner.
Thank you, Mayor. So I'm going to briefly introduce this ordinance and the reasoning behind it, and then we'll turn it over to Trevor Vaughn to talk about some of the particulars. But this ordinance is really intended as a deterrent for stealing catalytic converters, as I'm sure most of you know, and the folks listening as well. Aurora has one of the highest rates of catalytic converter thefts in the whole country, and so I really wanted to find something that was both enforceable and would act as a strong deterrent. And what this is intended to do is to really take away a market for selling those the catalytic converters after they're taken off vehicles. And so two primary changes that this will make. First, it defines catalytic converters as secondhand property, and what that means in practice is that they will become subject to the same rules as pawn shops. So if someone sells a catalytic converter, they have to give information about themselves, and so that creates a record and a tracking system. And then the other piece of it is if someone wants to sell a catalytic converter, or they can only sell one catalytic converter. If they have multiple, they have to have a business license demonstrating that they're in a business that would require them to sell more than one. So again, both deterrent actions. I do want to mention the Business Advisory Board did review this ordinance this morning. I wanted them to review it because of potential impact on businesses, and they unanimously supported moving this ordinance forward. And you know, as many of you are probably aware, Denver has a similar initiative, and my hope is that other cities across the metro area will follow suit, because it's really going to require a metro area-wide effort to take away the market for these catalytic converters. And so that's kind of a quick summary, and then I think Trevor probably has some details that he would like to add.
Not much. I think you pretty much covered that, Councilmember Gardner. Defining them as secondhand property ensures that when these items are purchased, that the seller's information gets entered into the Leads online system, which is the reporting system for secondhand property or pawned items of value. And there was a state law passed this past year that just required scrappers do record keeping, but didn't actually require that be reported anywhere, just that it be available for inspection. This actually will get it into the system so that it can be identified and analyzed. And then particularly as you see more etching of serial numbers or VIN numbers or some identifying marks and catalytic converters, that would need to be recorded into that system as well. We did approach our big scrap buyer last year. We thought under the existing ordinance of secondhand property that this applied, and they voluntarily report actually all of their purchases to Leads online. And we did have one other auto parts store that was buying catalytic converters and shipping them out of state that we required to license and report on this. And then the last part of this is this also includes adding gift cards to the definition, which we've historically enforced as secondhand property, but we made a note in the future to add that just to give it a little additional clarification inside the ordinance, as we've historically received a little bit of pushback on that. So happy to answer any questions on it.
Questions of staff or the sponsor? Seeing none, any further discussion on item number 3C? Seeing none, is there any objection to moving item number 3C forward? Seeing none, item number 3C will move forward. Item number 3D, moral obligation resolution, Hyatt Conference Center and parking garage. Teresa Sedmak, City Treasurer.
Good evening. I'm Teresa Sedmak, City Treasurer, and I'm here to present a moral obligation resolution related to a loan between the Aurora Urban Renewal Authority, or AURA, and NBH Bank for the purpose of refinancing the 2014 loan, which funded the construction of a publicly owned conference center and parking facility at the Hyatt Hotel. The hotel is located adjacent to the Anschutz Medical Campus within the Fitzsimmons Urban Renewal Area. The 2014 loan in the original amount of $27.75 million funded the construction of the project. The loan matures in December 1, 2024, at which time a balloon payment of $24.35 million is required to satisfy the obligation. The loan is being repaid through net revenues from the conference center and parking garage, along with property taxes, sales taxes, and lodgers taxes. A debt service reserve was established to fund principal and interest payments in the event that revenues were short of debt service. The 2014 loan has a moral obligation support from the city such that in the event funds in the debt service reserve fund are depleted, a request for appropriation is required to be made to City Council to replenish the reserve. The AURA board at its meeting of September 12th approved a resolution authorizing the refinancing of the 2014 loan. The new loan, or the 2022 loan, will be structured with debt service payments which coincide with the expiration of the TIF period, which is December 1, 2039. The continuation of the moral obligation support is required in order to close the 2022 loan. Mirroring the terms of the prior loan, the resolution before you authorizes the funding of a debt service reserve in connection with the 2022 loan and specifies that in the event a debt service reserve is depleted, in order to satisfy interest and principal payments, a request for appropriation is required in order to replenish it to its required level. The resolution also explicitly states that while it is the intention and expectation that the city makes such appropriation if necessary, the decision as to whether to appropriate the required fund is within the sole and exclusive direction and discretion of City Council. This resolution includes a waiver of reconsideration in order to allow staff to clear authority to act between meeting and the closing of the loan. This concludes my presentation. I'm happy to answer any questions you may have in this regard.
Questions to staff?
Mayor
I'm sorry.
Jurenski.
Councilmember Jurenski.
Yeah, I don't really have any questions of staff other than I would like a full presentation to come before the Planning and Economic Development Committee from the Aurora Urban Renewal Authority on this project of the convention center and the parking garage. I just find it absolutely unacceptable and sickening, the amount of debt that has been acquired and put on city taxpayers for this, and to be told that, well, basically, you know, the pandemic hit, we have no plan right now on what we're going to do, so we just need to refinance this loan is unacceptable. Every business in this city going through the pandemic either folded or found a way to make it and still is. So I just find this whole thing unacceptable and a sickening debt on taxpayers. So to city staff, I would like to make sure this makes it on the PED agenda very soon.
I know I did request it actually to come before study session. Is there anybody on staff who could tell me when it is scheduled, will be scheduled?
Mayor, we can get that to study session in October.
Okay.
Mayor,
Councilmember Combs.
I know that some of the questions were also about what's being done to make sure that the convention center is filled up and is successful. So we also include Visit Aurora and the Hyatt folks to talk about the efforts that they put in to ensure that this is going to be as successful inside.
Well, we'll certainly make that part of the presentation. A further discussion on item number 3D. Seeing none, is there an objection to moving item number 3D forward? Seeing no objection, item number 3D will move forward. Item number 3E, Veteran Service Officer Position Intergovernmental Agreement. Hannah Smith, Intergovernmental Relations Manager.
Good evening, Mayor and council members. As you know, the City of Aurora has an existing intergovernmental agreement with Adams and Arapahoe counties for a veteran service officer position. The position helps connect veterans to services such as healthcare, education benefits, and claims applications and processing. Council approved a renewal of this IGA in early 2022, and the IGA expires at the end of this year. Arapahoe County hires and supervises the employee, while Adams and Arapahoe County share the cost of the employee 50-50. The City of Aurora provides office materials for the position. Right now, the position is replacing ink at 2 times a year and is due for a new computer in 2024. The renewal is very similar to last year. The largest change from the previous versions of the IGA is the length, extending it to 3 years with an option for a 2-year renewal versus an annual renewal.
Questions to staff? Discussion? Seeing none, is there any objection to moving item number 3C forward? Seeing no objection, item number 3C will move forward. Thank you very much. I'm sorry, that's item number 3E. Thank you very much. Item number 3F through 3K will be given by staff in one presentation. Martha Alicia Montoya, Housing Community Development Manager.
Good evening, Mayor and council members. I have a presentation, so I'm gonna try and share my screen here. So give me just 1 second. Okay, and I just want to verify you can see my screen. Awesome. Good evening, everyone. My name is Alicia Montoya with Housing and Community Development. And the purpose of my presentation is to bring forward a set of agreements that we are proposing for your approval. This is in regards to the Housing Community Development Investment Financing Program, and we have been bringing these items through the Horns Committee, the study sessions, in the regular council meetings as well. The purpose of our program, the Community Investment Financing application process, provides developers with the opportunity to get gap financing and allows us the opportunity to build affordable housing in the city. We have had the ability to present this in the past, but I just wanted to refresh your memory on the program. And with the program, we have presented a few items, like I said, that we brought forward before on the different projects that we have funded with community development investment funds. In that, right now, we're looking at all of our HUD funds, so home, CDBG funding, and we are just getting caught up on those agreements that we have presented in the past. So we have some from 2020, which is the Jewel Apartments project. We dedicated $500,000 to that one. We have the Eagle Meadows, another $500,000 of CDBG funds. Also, just catching up from previous rounds that we have presented, the Jewel Apartments, we gave them a second round of funding for $300,000, and then building 93 and 81 units. Last, for previous rounds, we have for the summer 2021 round, the Aurora Crossing project with home funds of a total of $650,000 and 72 units. And then recently, through our summer round, we granted a second round for Aurora Crossing and another $700,000 of home funds. No new units, obviously, because this is that same project for Aurora Crossing. And then a second one for Imperial Duplex of a total of $640,000, 12 units, homeownership units funded with home funds. So this is the list of agreements. We had brought forward the agreements for Jewel Apartments, Eagle, in Peoria Crossing in the past. The new ones are the summer 2022 or summer and winter 2022 are Peoria and Emporia. The total for all of the projects and agreements that we are getting ready to execute is 3.29. With that, I wanted to know if you have any questions for me.
Questions of staff? Seeing none, is there any objection to moving item number 3F through 3K forward? Seeing none, then item 3F through 3K will move forward.
Thank you.
Thank you. Item number 3L, Kings Point Lease Agreement Amendment Resolution.
Thank you, Mayor. Marshall Brown, General Manager of Aurora Water. As we've discussed with council a couple of times in the past, we've had a lease agreement in place with the Kings Point development area that was recently acquired by Oakwood Homes to provide the lease of groundwater to them, and then an alternative supply should the groundwater run out. The lease that's been in place for a while was leasing 400 acre-feet of water per year for irrigation of a golf course in that development. The lease had a few challenges for both the city and for Kings Point or Oakwood. So we entered into mediated negotiations with Oakwood recently and have renegotiated a new lease agreement with them for groundwater. It changed a couple of key things from the existing agreement. The new terms are they would have the ability to withdraw and use up to 350 acre-feet of groundwater per year for the first 3 years of grow-in period for the golf course. And then they've agreed to reduce their use or the lease to 250 acre-feet per year for each year thereafter. They would have the right, again, as was the case with the existing lease agreement, to drill wells into the Arapahoe and Laramie Fox Hill aquifers to lease that groundwater. And they've agreed to limit the use of that groundwater for just irrigation of the golf course. So as I noted, the prior lease agreement was for 400 acre-feet per year, arguably out through 2095 or so, depending on some renewal periods of the existing lease. This new lease term goes for the same time period roughly, but does not require a renewal. It's simply based on the availability of the groundwater, and it's a significant reduction in the burden it would place on the groundwater, going from 400 acre-feet per year to 250 acre-feet per year. If the groundwater becomes unavailable during that lease term, Oakwood is solely responsible for the replacement water supply, which may, at the time, include negotiations or discussions with the city and or alternative sources as may be available then. So the city does not any longer have an obligation associated with that water supply. We are requesting that this move to regular session with a waiver of reconsideration due to the timing of the development in Kings Point that is moving forward.
Questions of staff on item number 3A? 3L.
Mayor.
Councilor Arcos.
So I'm glad to hear that this much more favorable deal is what's coming forward. Nonetheless, this has been a really concerning issue and a concerning set of agreements. So, Marshall, could you explain a little bit how we even got into this situation where we were obligated to potentially lease water all the way through 2095 and allow someone to use groundwater, which usually when we connect people to our system, we take over those rights. So how did we get into the situation that's such a deviation from our standard practice with respect to water and development?
Yeah, thank you, Councilman Coombs. The history dates back quite a few years, couple of decades actually, with the original annexation of the property. The property owner at the time did convey the groundwater rights to the city. That's a little bit oversimplified. It took a little while to convey the rights that they had, but the groundwater rights were agreed to be conveyed. And the city at the time, again, a couple of decades ago, agreed to allow them to lease the groundwater back for the purposes of irrigating the golf course. While that's not standard practice for sure today, it's not what we do today. It was more common back then. There were a couple of other golf courses that also had similar arrangements in southern Aurora to lease groundwater back from the city. So it was consistent with those other golf course agreements of its time. This one then progressed into the 2005 timeframe, and the city actually entered into a lease agreement that was consistent with the original annexation concept that formalized the terms and conditions for leasing that groundwater back from the city. It also had some terms and conditions that were consistent with a couple of other again, Blackstone and Heritage Eagle Bend golf course agreements that used contract terms to access the groundwater that had been conveyed to the city for purposes of irrigating the golf courses in all three situations. Now, this golf course didn't develop quite as soon as those did. So that lease agreement, and they all had some differences, but the concepts were all consistent and similar, that obligated the city to lease back the groundwater and contemplated future potential challenges with the groundwater supply. And each one dealt with those slightly differently, but generally considered the city offering an alternative supply. So we did offer to all three of these golf courses now alternative supplies. The Heritage Eagle Bend transitioned over to one of those alternative supplies. Blackstone is in the process of evaluating the infrastructure and the potential to switch over to an alternative supply, which would both be surface water based. In Blackstone's case, it would be reclaimed water. We offered that also to Kings Point or Oakwood. They're in a little different situation because they haven't built the golf course, and so they were not. The costs were pretty high for converting over to that alternative supply, which caused some concern for Oakwood, and that's what led to the mediation. Very well received, at least on my behalf and on city staff's behalf, was the reduction. They've committed to a very aggressive water conservation golf course that they hope and will extend the life of the groundwater for these purposes. And then they've essentially agreed to take on the obligation and costs associated with an alternative supply, should that be necessary. With the almost half reduction of groundwater use, it will definitely extend the life of the groundwater and puts us in a much better place. But a lot of, to your point, a lot of history and some obligations that were created for the city back in the 80s, 90s, and early 2000s associated with the leasing of groundwater for a few golf courses.
Further questions of staff? Seeing none, further discussion? Seeing none, is there any objection to moving item number 3A forward? Seeing none, item 3A will move forward. Item number 3M, Water and Sewer 2023 Rate and Fee Adjustments. Joanne Giddings, Deputy Director of Business Services, Aurora Water.
Good evening. I'm going to pull up my presentation here. So we wanted to talk to you tonight about what we've proposed in our 23 budget on our rates and fees. I wanted to start with a little bit of groundwork first. Rates and fees, sometimes we talk about them interchangeably, but they do support different things when we're preparing our information and how we determine our rate and fee changes. So rates is what we consider our operating revenue. So it covers our operating costs, which are the typical things you would think of: personnel costs, utilities, management, as well as some of our capital expenditures, which are our line replacements, valve replacements, maintenance on all of our systems, some of our software costs. So all of those type of purchases are done with our rates and funded through rates. Then we have our connection fees, and that is for new growth. So when we're buying new water rights to accommodate new customers that come into our system, or if we're increasing capacity or other parts of our system and adding pipes, those are considered connection fees. You'll see in this list that debt service is on both lists because it depends on what we're funding, whether we'll fund that with the rates or with the fees. This chart is showing, the red line is showing what overall nationally, what the average inflation for water and sewer utilities has been, which you can see is since 2010, it's been a 70% increase. When you compare that to what we have been doing with our annual requests for increase, we've increased since 2010, 29%, for an average bill increase of 2%. So we, in our original proposal for the 23 budget, we did have a 5% request. And in our planning in previous years, we had a 3.5% increase. So we knew at this point we would need to do some increases. We did hear some feedback from the committees, and my understanding is from some of you as well, that maybe 5% was a little high. So we did go back and take a look at the budget. We are now proposing a 4% increase in the budget, and we've done a couple of things. We did reduce the request for FTEs by 2. And then what we want to do is look at our credit card fees. Our credit card fees are continually increasing. And we have a number of ways that our customers can pay their bills. And there are a number of other ways that they can do it that was a lot less costly. So what we would propose to do is that we take some time to educate our customers on different methods of paying, and then we would do a lot of outreach that at probably mid 2023, what we would do is start passing those fees on to the customers if they choose to continue to use credit cards for payment. This chart gives you an idea of how much they have increased, especially if you go back to 2016, 2017, our budget has been about 450,000, and we've pretty much stayed in that budget until 2017, and then you can see it's increased significantly. So that's why we feel that if we have the customers that are using the credit cards, we pass that fee on to the ones that are using it, and then others that choose to use other less costly methods, we would still cover those costs. In looking at our overall operations budget, here's where our increases break down. And of course, we all know we also have some unknowns out there with the current economy and inflation. We're not sure exactly where it's going, but what we've done are put some increases here in our chemicals, our utilities, our equipment, repairs and maintenance. We're seeing some increases. And on the next couple of slides, I have some specific examples of what those increases have been looking like over the last few years. So if we start with our electricity here, you can see it's jumping quite a bit in the last couple of years. So that's a cost that we don't have any control over. And then in our repairs and maintenance, we're seeing the same thing, especially this year in 2022, we've seen some pretty significant increases. This chart is a really interesting chart. Maybe it looks kind of busy, but this is what our Binney treatment plant has been paying for chemicals just since April of 2021. So these are all the different chemicals they use, and you can see all of them have had some pretty significant bump at one time or another, and some of them are continuing to grow. And obviously that's an expense that we can't cut back on. So that's operations. And so that's where inflation is having some impacts on those increases. And those are some of the things that we're budgeting for. This is showing some differences in our 5-year capital plan. So inflation is a factor here as well. There is a index for construction projects and how much it's increased. And in 2021 alone, that increased by 10%. And so here you can see what some of the increases are and some of the specific projects that we're looking at. So we have a policy where we really try to maintain a small, incremental, regular increases. We believe that's the best for our customers to help them in their budgeting and how they can plan for making sure they're able to afford their water bills. If we don't do these incremental increases, and here we're showing right now what we're looking at is for the next few years, a 5% increase every year. We could choose to not do all of those increases, but then what you see happens is then we could have a couple years or even more of double-digit increases. If we do the 5% increases, that's probably $2-3 a month that the customer has to work into their budgets. When we do the double-digit increases, that becomes significantly more. So I just wanted to kind of show you how we kind of build our budget. So our operating and how it's looked over the years, you can see it's pretty predictable. We can pretty much plan that one out pretty well. Here's our debt service. So we know when we're going to need debt, so we can plan also for those increases. Here's the capital, and this is where it gets a lot trickier because we don't have like the same level of projects every year. It depends on which projects are coming up. So you do get the peaks and valleys. So if we choose to not have rate increases, you see this line here, we are not going to be able to keep up with all the capital needs, and we could get into real trouble. We could have higher costs if we delay some of these projects. With the increases that we've proposed, it pretty much evens out and we can get through all of the things that we need to do. So I want to talk a little bit more about the water rates, because when we say we are looking for a 4% increase, we don't necessarily increase all of our customers equally because it depends on how they're using the system. So here you can see residential is 5.7%. Multifamily is 1.2%, irrigation and commercial are 3%, hydrants 4%, fire protection is 10.7%. That percentage is a little bit misleading just because it's such a small number, so any increase, it looks kind of big. And overall, for the service charge, it would be the 4% increase. So because we have the 4 tiers, there is also some incentives here where the customers have some control over how much their bill increases. So the first tier is the 0 to 5,000 gallons, and that's kind of about where we're at for our winter quarter average indoor use. We're not proposing any increases there. In the 6 to 10, we have a small increase, and then see in tiers 3 and 4, we have the larger increases. That's where there's more of the outdoor watering. So we do believe this helps with affordability and helps promote some of the conservation that we've been really pushing our customers to continue to do. So this chart just gives you an idea. You can kind of look and see what your average monthly usage, if you're in the 5,000 in that lower range, it's not as much of an increase versus if you're a really high user, then it starts getting pretty costly, up to almost $20. And we did take a look at all of our customers just to kind of see how it would impact them. So you can see almost 30% will have less than $1 a month on average. Another 20% would be between $1 and $2. So there's 50% of our customers that would be under the $2. And then another 14% is under $3. So a good chunk of our customers are not going to see much of an increase. Once again, it's the high usage customers that will see the really big increases from this. So that's the water increase. For sewer, we're also proposing a 5% increase, in storm a 3.5% increase. These increases would be across the board. We don't have tiers or anything like that, so it's just a flat increase. One of the things with sewer is we do have Metro Water Recovery do most of our treatment for our sewer. They are increasing their rates 5%, and that is a large amount of our costs. So also in these inflation impacts our costs here as well. Here's some of our projects that are listed. We do have a lot of projects coming up in our sewer utility as well. So this chart takes into account all of those, the water, the sewer, and the storm. So we show for us that first orange line with the $91.10. With our 2022 rates, that's the average that a customer in Aurora would pay. With our proposed 23 increases, it would go to $94.85. So in this chart, we are comparing this to other 2022 rates because other utilities are going through the same budget process right now, and we don't know what their 23 increases are. So you can see we're still in that bottom third. We haven't jumped any other customers even based on their 2022 rates. That's without their 23 rates. So we still feel it's very affordable for our customers. So that's all of the rates. Then I want to talk just a little bit on the connection fees that we're proposing. So in 2023, we're proposing in water, in the chart we're showing 11.6%. That has a lot of variability because we've done a couple of different things in how we charge these fees. We're looking at how the water is used, if it's recoverable, non-recoverable. So there's a lot of different things that go into that calculation. So the actual increase will vary significantly. In sewer, we're asking for a 6.3% increase, and we are not asking for increase in stormwater. We then have projected out some increases, but we are working on some master planning. So at this point, those are just guesses. We will have more firm numbers in the future for those. So then when we're talking about the water connection, for those that continue to be kind of the status quo, they're under what we currently are charging, those developers will see an increase in their costs, an average of about $2,000. Under the new ordinance, in the same situation, they could decrease the amount of their costs by almost $1,000. So there's about a $3,000 difference. So there is some incentive for them to do some of our water conservation incentives. Then this is just a recap. So for 2023 in our budget, here's what we're asking for. In water, we want a 4% increase. Sewer, we're asking for a 5% increase. Stormwater, 3.5% for rates. In our fees, we're asking for, in water, about 11.6%, sewer 6.3%, and stormwater, we are not asking for an increase. So this will be an ordinance, and the typical timeline of how we do this is it comes along with the budget process. So for tonight's, we are just bringing this for information only. It will come as a separate ordinance from the budget ordinance at the budget workshop. And that's when you would determine to move it forward to the formal process along with when you decide on the budget. Are there any? Go ahead.
Questions of staff?
Mayor.
I'm sorry, Councilmember Gardner.
Thank you. Yeah, I have several questions because it seems like a lot of the feedback, and I know I'm just one of 10, but a lot of the feedback that I gave at the Water Policy Committee wasn't included. One specifically is on the credit card processing fees. I feel really, really strongly that cost should not be passed on to consumers. That is the cost of doing business. I don't know, one of the suggestions or recommendations that I had at Water Policy Committee was, go back to our credit card processor and or find an alternative. It's a process I'm very familiar with, and see what kind of rates we can negotiate. But, one of my biggest concerns is, especially underserved populations that don't have access to a checking account. In a lot of cases, they use things like prepaid Visa cards, and we are going to charge them a fee to pay their water bill. I can't get on board with that. But I'm curious what, if any, efforts were put into negotiating better rates, either with our current processor or going to find an alternative. It sounds like, well, I don't want to say if it was done or not, but it wasn't talked about if it was.
And so that's a good question. We have been having ongoing discussions with our credit card vendor. You saw the curve on the graph that was shared by Joanne earlier, where credit card fees were approaching, well, they were above $1.5 million. They were actually up to about $1.7 million a year. And the negotiations we've been having have resulted in a significant reduction of the fees. We think there'll be about 1.2 million moving forward. So those were fruitful. Keep in mind, $1 million a year is 1% of our rates. So when we were asked to come back and rethink how we might be able to reduce or keep the water rates more manageable, we don't have a lot of discretionary things that go on in the utility. And so the $1.2 million of ongoing costs is primarily how we were able to avoid 1% of the rate increase. So that's the offset we were proposing there, even though we did have at least some success with the credit card vendor in getting the fees more under control. We do think also that the demographics that appear to be using the credit cards are a little more skewed to, and we heard from the credit card vendor that we have a lot of people using rewards cards right now. And that's one of the reasons that the credit card fees can't come down more than what they already did, was because they end up paying large fees associated with rewards cards for mileage or points or whatever people are using rewards cards for. Yeah. So it appears we have less of the challenged population who's limited to just that form of payment. From what we can tell, a lot of those people are using the Western Union service and services similar to that. So there's a lot, as you noted, there are a lot of options out there for paying. And what we're proposing is to really get out there over the next 6 months and educate the customer base on what all those different options are to minimize their cost and to minimize our costs. Still leave credit cards as an option, but again, if they choose that option, they would end up with the fee associated with it, but really trying to shift to the myriad of other options that are out there.
Yeah, and I appreciate that. I think what my frustration is from a philosophical standpoint, the three entities that I can think of, Water Now, Xcel Energy, and the Department of Motor Vehicles, all charge a fee for paying by a credit card. And what do all three of those have in common? They don't have any competition. They are government or quasi-governmental entities. And they are not subject to competition. I can't go get my water from somewhere else. I am forced to get it through Aurora Water. I'm forced to get my power through Xcel Energy. I'm forced to go to the Department of Motor Vehicles to register my vehicle, all those things. And I think that's what my frustration is government is saying, hey, you have to pay us this. And oh, by the way, we're going to charge you a cost for the convenience of paying us. Like, I have an issue with that. And, I understand the costs associated with that, but that's a philosophical objection that I have. We may not agree, or, there might be, we may have to do it, but I just have a philosophical objection to that. And that's really where I'm coming from. I think, so my other question is, let me think how to ask this. What impact did the most recent the water conservation ordinance have on water rates? And because when that presentation was happening, the comment was made, if we have to increase water rate, or if we don't pass this ordinance, we're going to have to increase water rates. And now here we are shortly on the heels of passing that, increasing water rates. So what impact did passing that ordinance have on our proposed rates?
Yeah, so good question again. The impact of not passing a water conservation ordinance on our water rates is that the volumes of water, the additional volumes of water we're having to bring into our system right now are lower quality. So the high quality, more pristine water sources that are easier to treat are already in our system. So we already have acquired as many of those as are out there that we can. So now when we go acquire new water rights, they're of lower quality. So as we bring them into our system, they increase our treatment costs. As our treatment costs increase, that cost gets passed along to the ratepayers. So what would be difficult, even though we could show some projections of those cost increases, it's kind of complicated because there's a lot of factors that go into that. But the lower quality water, a little bit kind of, I wouldn't say oversimplified, but kind of consolidated in a short answer is raises our treatment costs. That gets passed along in the rates. And so we're trying to offset that in two different ways. One is the conservation ordinance that lowers the use overall, allows those higher quality sources to go further and keeps the rates lower. The other thing we've done is in the structure of the rates themselves, the lower volume uses are, and this has been in our rate structure for quite a while, but the lower volume uses don't drive as many of those costs for treatment and pumping in that case, associated with the peak uses. So as you lower your irrigation peaks, you also keep the pumps within their operating curves more frequently. So pumps have efficiency curves. And if you can keep them within the efficiency curves, they're more cost effective to operate. They're more efficient. When you deal with peaks, primarily associated with irrigation, it drives those pumps out of their curves pretty frequently and drives higher operating costs in the system. So those are the two ways that the water conservation ordinance and our rate structure are helping minimize costs to our customers, where if we didn't have ways to minimize outdoor irrigation or those outdoor irrigation peaks, the costs would be passed on to the ratepayers.
Okay. And then my last question or topic is to make sure I understood correctly, because it was a little unclear. This will not be voted on as a separate item. This will be voted on as part of the overall budget? Or
No, it is
did I get that backwards?
It will come with the rest of the budget, but it will be a separate item, so council members can vote separately on rates and fees outside of the rest of the budget.
Great. All right. Appreciate it. Thanks, Marshall.
Marshall, Mike Hoffman, I just want to say, well, first of all, thank you for all your work in the department. I think it's extraordinary, but I really do appreciate that you're making adjustments on an annual basis. I think, let's not be a Westminster, God bless Westminster, but where they went for a number of years without doing a rate increase and then did a very significant rate increase. And there was just, I think, a rebellion by the residents of Westminster over the cost increase. I think it's better to make the adjustments on an annual basis and to make them truly reflective of the cost and not beyond what the immediate cost of delivering the services are. Further questions or comments on
Mayor Sunberg?
Councilmember Sunberg.
I have a question for Marshall regarding this outstanding, mind-boggling 71% increase in electricity cost since 2019. Is that something we just look to Xcel Energy and wonder why, or internally, are we using more pumps, or what's the explanation for that? First of all.
Yeah, great question. And some of it is associated with rate increases that we get from Excel, and we actually have a couple of other electric providers as well. And so typically when they do their rate increases, similar to ours, they don't affect all customer classes exactly the same. And more often than not, large industrial customers can be affected a little more than single family residential. But the other thing that's going on, it's not entirely just we can blame it on the rate providers. The other thing that's going on, and this goes to Councilman Gardner's question also, when the things we have to pay for when we bring lower quality sources in, and or when we get new regulations, water quality regulations that hit us from the federal government or the state, it drives up our chemical costs significantly, and it drives up our power costs significantly. So we have power costs that go up. I talked about the pump curves a little bit. We pump a ton of water. We also have, and the Binney Water Purification Facility is a fantastic facility. It's industry leading. It positions us well to deal with emerging contaminants, things like PFAS. But we utilize a process there called advanced oxidation. It's a combination of ultraviolet light and hydrogen peroxide concentrated to break molecules apart. It's a highly energy intensive process. So the more lower quality water we bring into the system, one of the ways it shows up directly is in energy costs. Our power costs start going up significantly. Anytime our volumes of demand go up, it drives those treatment process costs up, and the pumping costs get driven up as well. So our power is a combination of rate increases that we get hit with, and increased demands, and additional water quality challenges, and more lower quality water that we're having to bring into the system and send through the more energy intensive processes.
Thank you. And just a couple comments. I like how it's structured in that those who are using very little or very much water at all will not see hardly anything for an increase. Those who are using more will, and in and of itself, that is an incentivization to conserve water. And here we are in a time where we're experiencing inflation across the board in so many sectors. And I think that as we want to protect our citizens and residents from increases, they are going to be a little bit more understanding of rate increases based on costs going across the board.
Thank you.
Further questions or comments?
Mayor.
Councilman Jaworski.
Yeah, Marshall, I was just wondering, how often do we check with other carriers for credit card processing fees?
Yeah, so we had, our vendor for credit card payments, we went through a negotiation a couple of years ago. And so not all that frequently, more like every 5 to 10 years. We did do it a couple of years ago and switched vendors, put what we felt was a more protective contract in place. In hindsight, there were a couple of things we wish we would have tightened up more in that contract. So we can definitely look at that additionally. We do think it's a little bit of a trend in the industry where those fees and things have been trending up for others, not just us. And one thing, Councilman Gardner made a good point earlier about government entities. People don't have a choice of where they can go to pay for their water service. We are sensitive to that. We're aware of that. One of the things that maybe a slightly different perspective is if you have a choice of where to go shop for a service, you can choose just strictly based on the cost, and they build costs in or they don't build costs in, and you as the consumer get to choose. We do have a philosophy of trying to be as transparent as possible, not subsidizing or covering fees in our rates. And that that's part of why, kind of going to the philosophical discussion, why we are in favor of eliminating the subsidization on credit card fees, because most of our customers are not aware that they are subsidizing those who use credit cards. So we want to be also as transparent as possible.
Mayor, can I ask?
Councilmember Jersey.
Yeah, so I do know that legislation was passed to allow credit card processing fees to be put back on consumers and customers. That's been something that has gone through the service industry, my industry, rampantly, and you now see, you have the option to add it as a line item charge on your bill and put that back to the customer. I guess my only issue is, like, in my industry, it's very transparent. It would be on somebody's bill, and also they would have the option to pay cash, go to an ATM, which are located in most bars, and those fees, ATM fees, are even less than what some of the credit card processing fees. And I know that I personally have had residents from Heather Gardens reach out to me concerning not being able to drive their payment, whether I'm not sure that it would be cash, but maybe a check, over to Aurora Water. So without, the city building being totally open again and people being able to just walk in and pay their bill, and without them really able to have that alternative to drive their payment over, whether it's cash or whether it's check, I have a hard time putting these fees back on to our residents.
And if I could clarify a couple of things, we're also sensitive to that. So we do accept payments downstairs in the AMC now between normal business hours, essentially 8 to 5, Monday through Friday. But that said, we're also looking to expand. And this is one reason why maybe mid next year makes a little bit of sense also, because we're moving into a facility in the south, and we're also going to open that facility up to take walk-in payments. We've also been looking at a kiosk option that we could put in some libraries, potentially in more areas of the city. There are costs to the kiosks, and so we're having to evaluate costs and capabilities, but we're trying to expand payment options as much as possible. And so we would be, over the next 6 months, sending out a lot of communication on all those different options, where people can walk in, where they can actually go pay alternative electronic payment mechanisms, etc. So we think we're going to have, we know we've got a pretty robust portfolio of options, and we plan on increasing it.
Further questions or comments? Seeing none, this was for information only, so.
Mayor, could I just mention, I know it's been long, so I won't go through, but there are a couple of more slides on our Rural Water Cares on our assistance program. I'll just mention that they're out there for you to go look at, showing some of our statistics and things. So thank you.
Thank you. Item number 5A, Rules of Order and Procedure Amendment, mandate fiscal note for council. Councilmember Allison Combs.
Thank you, Mayor. So this has been an issue that has come up multiple times. We are going to be looking at our budget very soon, and we've passed a number of items without any real knowledge of how they're going to impact our budget. So this year, we won't see those budget impacts, but in future years, as we see the cost of any proposal that council brings forward, it could have an impact on the other services that we provide to residents of our city. It's pretty standard practice within any government to have a fiscal analysis of the impact of policies that you're being asked. In particular, in the Colorado State Legislature, and any other body that requires to provide a balanced budget, which includes the city of Aurora. It's standard practice to have a fiscal note to identify the cost of what you're bringing forward, and then also to identify a source of revenue in the budget process. So this only requires, or really all it says is you're subject to a motion to continue if you don't bring a fiscal note. I am open. I've heard some suggestions, though nobody came to me with them directly, but I've heard there's a suggestion that we identify the actual source of revenue offset and to that, as well as the possibility of having staff determine if there is a fiscal impact and requiring it to go through the full process. So study session or policy study session and regular council meeting if it's identified that there is a fiscal impact, to give staff the opportunity to provide that information to council. So the only thing that's listed here is just subject to a motion to continue if there isn't a fiscal analysis included, but I'm open to those other suggestions, which I also have heard are.
Further questions or comments? Let me just say, I'd like to, I'm sorry that I didn't have the opportunity to talk to Councilmember Coombs before this meeting, but I'd like to add a provision that I think strengthens, I think, the direction of her amendment to the rules. And it in effect is when I entered Congress, it was called the pay go. And so that in effect says that if in fact you are doing something through the budget process, they would call that the appropriations process in Congress, then you don't have to do an offset. And that works much better here because we have a balanced budget requirement anyway. So if you're cutting spending, or you're reducing taxes, cutting taxes that reduces revenue, it has to balance at the end of the day during the budget process, adoption of the budget. Same thing if you're adding another spending program, you know, you have to have a balanced budget at the end of the day when you adopt a budget. However, after that process, once you've adopted the budget, if you're then going to cut taxes, you should identify an offset in terms of reduction in spending. That would be an offset to that. Or if you want to enact a spending program, you should also find an offset in the budget to cut spending to again be an offset to that. So it's a fiscally conservative measure. I think it works well, and I think we should adopt that with the Coombs amendment as part of the Coombs amendment. And I will say that I think to the Coombs amendment, I think every item, I think actually I'll be looking to work with Councilmember Coombs maybe for stronger language before it comes to the floor, because I believe that every proposal going forward should have a fiscal note period before it goes to first reading. Even if it just says no fiscal impact, even if it's a savings to where it's positive fiscal impact or it's a negative fiscal impact. I mean, everything should have a fiscal impact. And that's just, you know, and that's how it's done in the state legislature. That's how it's done in Congress. And there's no excuse for not having it. Because all it is an estimate based on assumptions. And so they're never exact. But they spell out the assumptions that they use and they write a fiscal note accordingly. So I think I think stronger language would be appropriate in that regard. Further questions or comments?
Mayor,
Councilmember Coombs.
I'll just say that I take that to be a friendly amendment, and I'm happy to sit down and work out the specific details for it.
Thank you. Then Councilmember Coombs and I will be working together to strengthen, I think, what she's trying to do to really turn into a mandate. I've been very disappointed seeing proposals come through that have a fiscal impact where we're voting on something where we have no idea what the cost is. Further discussion.
Mayor?
Councilmember Lawson.
Okay, I just had a question. So I understand you're gonna work on maybe strengthening the language in here, but I guess what I wanted to know is how do you, and this is for the sponsor, what do you determine as adequate information? I mean, is that gonna be with what you're gonna be working with the mayor on to kind of strengthen that? What does that look like, adequate information? Because what does that include? You know, I presented fiscal notes, but I don't know if it's adequate or not. I think it substantiates what I'm trying to do. For again, with the Youth Violence Prevention Program, I provided a fiscal note. So is that adequate? What is adequate information?
Yeah, so adequate for council to make a decision. So it's subject to a motion to continue, right? A motion to continue still gets voted on. And I think that's where the mayor is looking for strengthening the mandate. The reality is at this point with all of our rules, they are only as enforced as we as a council choose to vote to enforce them. And that applies to this as well. Right? I can't force people to follow the rules because the only consequence of not following the rules is a censure, and that's up to the majority of council to enforce as well. So this is similar, right? It's up to the entirety of the body to recognize the need for fiscal information about the decisions that we make, and then vote in support of a motion to continue if it's not there. So I do agree with the mayor actually that if there's some way we can give this more teeth, I'm very much in support of that. But yeah, at this point, it's just being subject to a motion to continue, which means 6 members have to agree that there's not enough information.
Mayor.
Mayor.
Councilmember O'Connell.
Thank you, sir. As a co-sponsor to this resolution, I would just answer Councilmember Lawson's question, which I think at a bare minimum, an estimated number of like the budgetary impact. Ideally, I'd like to see like if it's a proposal that might add FTEs, basically how many FTEs, an idea of like what those positions will be responsible for, in addition to the budgetary impact. So as much information as we can provide, I think within reason, taking staff time into consideration would be appropriate. And I'm also supportive of the pay-go provision, since unlike the federal government, we don't print money at City Hall.
Further questions or comments?
Mayor Zabonik.
Councilmember Zabonik.
Yeah, no, I agree with this this idea, and would just say that I think adequate information. This is where it will be really dependent upon staff to provide this for us. They should be doing this. I think anytime we offer a proposal, it should be incumbent. This is where the rule should really direct staff to say that it comes forward with a fiscal note where they do their best estimate of what the cost will be. Now, I do. This is true whether it's in Congress or in the state legislature. We have to recognize that these are static estimates, right? So it's only considering the impact to the city. We're not suggesting that when we do things like put more criminals in jail, it costs the city, but what does it save taxpayers? What does it save? And we live in a dynamic economy, so it doesn't take that into consideration, but it's a useful data point. And I think we should have it for every bill or every proposal that's brought forward.
Mayor.
Councilmember Cruz.
So just to clarify, as far as the staff point and the staff following through point, our current rules do say provide adequate time to allow city management to provide a fiscal impact or fiscal analysis. And so I think that's part of the issue that has arisen is things sometimes coming forward without adequate time for that analysis to be provided for all the department heads to be contacted to assess that. So that's part of the purpose of suggesting the most to continue as the remedy is that then there's time to provide that information. But again, preferably that is there when we come forward and we're making sure that staff have to provide that before we bring it forward.
Let me tell you, I really think this isn't very hard for staff to do once they get the hang of it. It's just not very difficult. I mean, I think like Councilmember Marcano said, if there are additional FTEs, you estimate that they know exactly what the cost of those FTEs are going to be, according to that estimate. And any other costs, staff time, impact to the city attorney's office, those things. I mean, this is not that hard to do. And if in fact they're off, um, it, let's say unfortunately it costs more than it does, then they'll come back, or let's say they expend, they have a fiscal note for X number of dollars. They run through those dollars before the end of the budget year. Then they have to come back to council with a supplemental appropriation for the difference in what they project will get them to the end of the budget year. And obviously that's not good budgeting, but it gives us the opportunity to look at why the assumptions were off. And of course, it's a very inexact science, quite frankly, because some of these things, like on Councilmember Jurenski's proposal on the retail theft, that they have to estimate how many individuals could be incarcerated in our detention facility. So that's going to be a raw estimate based on whatever information that they have currently. It's a guesstimate, but it's important to do that and to put dollars associated with that. I think the dynamic elements that Councilmember Zelinski, I just merged Councilmember Jurenski and Councilmember Veronica together. I think that's something that we all would understand and be able to debate, but that's really not part of the fiscal process. That's part of our debate on the floor. I just have a question for the city attorney, and that is office, and that is there a stronger way to? Does this really need to be an ordinance and not a resolution to make this? If we're going to strengthen the language to make this a mandate.
And so what you have before you is a resolution as to the council rules. So council rules obviously apply to council, not staff. If you want more teeth to this, you actually put that requirement in an ordinance, and then it's something that staff needs to comply with to bring things forward.
Let me ask Councilmember Coombs. I think that we earlier this evening we took Councilmember Gardner and Councilmember Jurenski's proposal on the sedatives used by AFR. We converted that from a resolution into an ordinance to take us to the floor. I would ask Councilmember Coombs to also consider doing that to this proposal as amended to change it from a resolution to the ordinance so it really truly has support of law. Councilmember Coombs.
Yeah, to do that. As I said, I'm happy to do whatever we need to do, workshopping things to make it as strong as we can. Councilmember Marcano, are you on board with that as well?
So yes, but there is a caveat, and that is if City Manager Twombly, who I think is still on the call, do you feel that the executive branch of the city currently has the staff resources to, in a timely fashion, since this would be, basically now under force of law, perform analysis for policy proposals from council?
Yeah, I have to say that it's, we'd probably have to look at this on a case-by-case basis. It really depends on the complexity and extent of what's being proposed. So there are some that would probably be fairly simple, like the mayor says, and there may be others that would require more resources to handle. I expect it's something that we would have to just, we've been doing it somewhat in some cases, but we'd probably have to let our experience, dictate in the future what resources we would need.
Okay.
And let me just say on the pay, well, first of all, I do think, this has to be done. Council cannot be making decisions without understanding the cost of the ramifications of what they're doing. And so this is just basic government. In the second part of PAYGO, that actually puts the burden not on staff but on the individual member bringing a proposal forward. I mean, if you want to, after the budget's adopted, if you then want to bring forward a proposal to reduce taxes, then you have to find an offset. It is the council member or the mayor who brings a proposal forward, for example, that either cuts taxes or creates a new spending program after the budget's adopted, then that member, in fact, it's not the responsibility of staff to find that cut. It's the responsibility of that member to look at the budget and identify where in fact they're going to draw that savings from. And so actually that burden is not on staff. Further discussion.
Mayor.
Councilmember Jurenski.
I mean, if you want to call me out, just call me out. I'm the one that has a tax cut coming forward. When we have a surplus in our budget and we ended up $20 million over budget, I'm not certain why I need to find a way to replace that. Obviously, we are overtaxing our citizens and or our businesses. So I'm not sure why in that scenario, I would need to find a way to replace that money and then further somehow tax or implement a fee on something else. So I'm not really sure where.
Yeah. Let me read this to you because I would encourage you to read the language, because the language says when a council member sponsors an item that has not been considered as part of the standard city budget process, and will require the expenditures. So if you look at the language, it essentially says that you could introduce your proposal, given the fact that there is a potential surplus during that budget process, and thereby not have to identify a cost savings. However, once the budget passes, then in fact, prior to the next budget, the adoption of the next budget, then you would have to identify the cut.
Mayor, I understand that completely. And the timing of my tax cut coming forward will be to policy committee before the budget meeting, but will be to full council after the budget meeting. And I'm still not sure why, and that would be when the budget was adopted. So I'm still not sure why, with a surplus in the budget, why I would have to seek a way to replace that. We were.
Let me ask a question of the city attorney in that regard. Wouldn't Councilmember Jurenski be able to bring it forward during the budget process itself?
Sure.
As part of the budget process.
Absolutely, that could be part of the budget process, or you could do it separately. And actually, what that language is identifying is you could identify use of the surplus would fit this language as well.
Further discussion. Seeing none, is there any objection to moving item number 3A forward as amended? Item number 3A will move forward. Item number 5B, City of Houston homelessness response briefing. It is Council Member Marcano who really initiated and led this effort. And so I will yield the floor to him. And then next month, I hope more members can go. We will be going to San Antonio to view that program as well. And Councilmember Zvonek has initiated and showed the leadership to put that program together. And so he will be giving the briefing after the San Antonio visit next month. And again, I would encourage more members to go if they haven't signed up. Then Councilmember Coombs will give her comments, and then I will have some concluding remarks, and then we'll open it up to the floor. Councilmember O'Connor.
All right, thank you, Mayor. Could I please get sharing privileges? All right, thank you. See if I can get this to work. And all right, are y'all seeing the right screen?
Yes.
All right, awesome. Thank you. All right, and thank you, Mayor, and my colleagues. And really, I want to start by thanking Deputy City Manager Venegas and Jessica Prosser and Hannah, who really helped work out the logistics for the trip. I think it was really, really fruitful discussion. I think there was a lot that folks took away. And I also want to thank our intergovernmental partners, Commissioner Jackson, Commissioner Henry, Council Members Hines and Sedabaka, for coming along as well, as well as their staff delegation, because this is, as y'all are going to see, truly at the end of the day, a team effort. So, yeah, I guess I want to start by discussing kind of what the status quo was in Houston. And I think it's really well exemplified by this kind of mess that you see before you here, which unfortunately, I think this is a kind of a similar situation to what we find ourselves in. And this is basically their old homelessness system. So you can see there's a lot of arrows kind of flying all over the place. There wasn't any kind of centralized way where folks who are experiencing homelessness could go to a location and get connected to the resources that they needed. There was a lot of reliance on word of mouth or just on good fortune from folks hearing from someone else or from providers collaborating as opposed to competing with each other. So there was a lot of inefficiency, and they found themselves both from a service delivery standpoint, as you see here, but also from a funding standpoint, in a similar situation to where we're at right now, where what we basically have is a really great way to manage homelessness, but not solve it. So we can keep folks alive, we can keep folks fed, we can temporarily move them into shelter. There's other opportunities that are afforded, but we can never really address the root cause. And that's where our local continuum seems to be falling apart. So what Houston did is they took what they had and through, in part through a federal mandate, they got funding from the FHA or from HUD after they were basically identified as a problem area for housing. And they did what I think is extremely, not only has proven to be effective, but I think it's just a logical thing to do. So they broke down that dysfunction and rolled it into a central agency. They basically identified a local non-governmental entity, which ended up being the Coalition for the Homeless of Houston and Harris County, and made them basically the one-stop shop for homeless services. But it wasn't just taking this random board of people and giving them that great responsibility. It was done with help from consultants and experts in both the public and private sector to really mold that organization into one that was capable of holding this great responsibility and, more importantly, executing on the great task that was given to this organization. And I want to stress to you all, this didn't happen overnight. They kind of built the plane while it was in flight, but it has definitely worked out, and we will talk about how that happened as well. But what I want to point out with this slide here is that they have the steering committee for this coalition. That is basically the primary decision-making body. This is where the buck stops, ultimately. And from there, they created specialized bodies for specific areas. And, veteran homelessness, of course, is a large issue throughout the United States. And they laser focused on veteran homelessness to start because it's an area where everyone, I think, is in agreement that folks who serve our country do not deserve to be living out on the street. That's abhorrent and that's a failure on our part. So that's where they started. And from there, they expanded. After they saw success there, they got public buy-in from the community, private sector buy-in, because they had a united mission and vision as an entity. And with that private sector buy-in actually came philanthropic support as well. which allowed them to rapidly expand the program and who they were serving. So getting that initial success by targeting the veteran population was critical, I think, to get their program to the point where it is today. So how they did it was not through doing a little bit of this, a little bit of that, maybe a touch of work first here, maybe some pallet shelters here, maybe a little bit of housing first here. They just said, no, we're going to scour the country, find out what the best solution is based off of evidence, and implement that. And the coalition that they put together, the elected leadership, the private sector leadership, and the philanthropic groups were all on board. And it's that commitment to that same mission that has given Houston the incredible results that it has today. So 26,000, I think, people have been housed over the last 11 years. They have a 63% reduction in their point-in-time count population, which is enormous, given how huge and densely populated the Houston metropolitan area is. And the most important thing that stuck with me is that they have a 90% success rate, meaning after 2 years, people who are enrolled in that program are either identified as needing permanent support, folks that would have, let's say in the Reagan era, been institutionalized. There were issues with the institutions, clearly, but this is a much more humane and effective way to house people. Then there's also, and then the remainder are folks who are able to become self-sufficient, either through benefits or through employment, or a combination of both. So one of the big things that we came away from that with as well is that it's actually the fiscally conservative thing to do as well. So not only are they posting incredible results, they are spending a fraction of what they were spending, basically managing homelessness. It's the same kind of thing that we've identified here in the Denver Metro, where, I think it was with the Common Sense Institute came out with a figure, I think it was between $40,000 and $120,000 are spent per unhoused person in the Denver metropolitan area. So Houston's figure was much higher, as we'll see in a little bit here. So what is permanent supportive housing? Because when I've brought this up in the past, there are folks who seem to think that basically you get free housing for the rest of your life. And that is by and large not true. Again, there is that small percentage of the total unhoused population that have such high acuity needs that does end up happening. I think we can all agree, though, it's better to have those folks who desperately need that support be housed than suffering visibly exposed to the elements and all of the other risks that come with that. So what they did was they implemented their permanent supportive housing strategy, which is basically, as you see here, new units, whether they are brand new builds that were already subsidized housing, which are few and far between there, same as here, or by picking up market rate units, which is what was basically the key to their initial success. That has slowed down. We'll get into that in a little bit here. And the most important part of this is that it's not just a unit of housing by itself. They created service support teams that basically provide those wraparound services that makes permanent supportive housing such a successful program. Because it is not enough to just toss someone into an apartment and say good luck. They put people into housing and provide them with whatever supports they need, whether it is mental health, behavioral health, job training, and more. So it's a big list. We'll see that in a little bit here. But that is how that system has worked so well for them. And that was done, again, as I mentioned, through a sort of public-private partnership. Because one thing that I found really interesting is the city of Houston actually has no general fund line item for homeless services. We do, and that's actually an advantage that we have when we're considering an approach like this, because we can depend a little less on the private sector. And frankly, our private sector here isn't quite as big as Houston's, though it does exist, and I'm hoping we can get them on board as well. But it's through that blend of funding sources that they were able to, I think the way that they put it was weave together the necessary budget for each person that they housed. Here's kind of a map of how they did it. And one of the things I want to point out to y'all here is that this was not done in a single concentrated campus. In fact, Mark with the city of Houston repeatedly, told us a campus is expensive, it's a money sink, and you don't get the best results that way. So Houston's approach was to basically utilize existing properties, existing vacancies, new subsidized housing properties as they came online, and some degree of existing hotels and motels that could be bought and converted into permanent supportive housing. As you can see here, Houston's a massive, massive city. I think the entire Denver metropolitan area would easily fit within this map. The sites are scattered, basically, based off of a combination of access to transit, access to employment, and access to services. So that make sure that folks aren't kind of just put out into the wilderness and, they're able to be checked up on and get access to the services that they need to succeed. So this is actually a flyer that they created for their landlord recruiting program. And I think we still have Jessica on the line with us. And Jessica, I'm going to ask, how many landlord recruiters does the city of Aurora currently have? Or Emma or
Good
someone.
evening. Good evening. So we currently fund one landlord recruiter that's employed through the Aurora Housing Authority. This landlord recruiter focuses a lot on families and some chronically homeless, and does have a pretty robust network of landlord recruiters. But that's something that's an identified need for additional capacity there, as we would prefer to utilize all the units we have available currently, that's a lot cheaper for just getting folks that are in programs with vouchers and not vouchers to get housed.
Thank you, Jessica. And I point that out not to pick on us. I think we're doing the best we can with what we have. And to remind you all, this is a regional approach that Houston has done. So I think they have a small army of landlord recruiters. I think it was around 25, if memory serves. And those folks do what our landlord recruiter does, but all over the Houston metro. So that's how they've been able to identify so many available units of housing, and why when they, now they've, sorry, let me back it up. Why when they initially started, they were able to start housing people very quickly because they already had some of those folks in place. And the initial turnaround when this program kicked off, back when, as I mentioned, they were building the plane in midair, they were able to house people as quickly as 3 days from being initially contacted, which is incredible to me. Today, it's a little slower because the market has tightened, but that's also why these landlord recruiters are so important. And what we heard anecdotally from the folks we talked to, we've heard this from Mark in the past when the mayor and I have met with him, is that as you can see here on the flyer, they guarantee the rent and utility payments. They guarantee that these folks are very unlikely to be evicted, and that there's always that supplemental tenant management team to provide these folks with services. So what we heard is that there are actually landlords who would reach in after they had their initial, contact with the Continuum of Care or with the Coalition for the Homeless of Houston and Harris County, because their tenants were great tenants and actually better than the market rate tenants in many cases. So, building a good relationship with with our local apartment association and having the backing of elected leadership, private, leaders, and the Continuum really makes a huge difference when you have that united front, because it gets folks off the streets and into housing with these supportive services, with the cooperation, of course, of the private sector. And here's a little more detail about their integrated care teams, because this is when we're talking about permanent supportive housing, this is the support that makes the housing eventually become permanent for the people, not a permanent cost to the public sector, but permanent for the folks who get into the program. So medical services, as you see here, I'm going to just highlight a couple of these. There's mental health counseling, detox and substance abuse, life skills training, and job training and employment. And I point those out because those are typically some of the more expensive things that you see when you break down the costs of managing homelessness as opposed to putting people into housing. But when you put folks into housing, the ER is no longer their primary care provider. They're able to actually get detox and these other services without having to first be, arrested or contacted by EMS after a concerned citizen makes a call because someone's acting erratically out on the street. They have shelter and they have access to these services through this continuum, so you can actually address these issues before they publicly manifest. So it reduces costs, improves outcomes all around. It's very exciting to see. Here's an important comparison, especially since we were talking about San Antonio, which I am excited to go see. This is major cities from 2011 to 2020. And I just want y'all to see the stark difference here. Houston is leading the pack with a 57% reduction over this time period. San Antonio, 9% reduction. Modest, still a reduction, but when we're talking about cost benefit, Houston, clear leader of the pack here. So I just want to point this out here. That shelters and campuses, basically, as I mentioned earlier, as we were told, are financial black holes. Basically, they're money pits. There's huge upfront costs to building that, and the money is frankly better spent on temporary solution, directly on housing as opposed to temporary solutions like sheltering, even our own pallet shelters, tiny homes, etc. The number of folks who are experiencing homelessness seldom really accept traditional shelter. I think that's something that we all know. That's something that the data bears out, what we're seeing with our homeless outreach team now that we have a camping ban. The number of folks who take us up on other options like our pallet shelters is a little higher, but still nothing comes close to the acceptance rate for permanent supportive housing. Per Houston's data, that basically ranges between 91 to 94% acceptance for each camp that they go and close. And I say close because they're not in the business of sweeping camps like we are. They only close down camps once they have housing for the people who are impacted. And that's because early on, when they were dealing with their homelessness program, just like we did before we had a formal camping ban, they had a policy that allowed them to move folks around. But they realized they were just setting money on fire and not impacting the unhoused population. So they stopped doing that and instead got into this rapid housing first strategy that's really made a visible difference for the population in the city. One sec. There we go. So here are like the three key components to their strategy. And the good news here is that we have two of these. We have the diversion and we have the rapid rehousing, and they do a really great job. But the issue is, as you see here, they support folks who are low to medium acuity. So it ends up being the folks who need the permanent supportive housing with these wraparound services and whatnot that we end up seeing out on our streets, out under ILIF and I-225, as I saw earlier today coming back from City Hall, out in the Jewel wetlands, where we just recently had a large camp of folks who were pushed there after being swept from elsewhere in the city. So that permanent supportive housing gives those people a place to actually go and get on the path to recovery, as opposed to, what we're currently doing. But I will say our rapid rehousing and our diversion programs, especially during COVID, made a huge difference in people's lives. So the folks who are, in charge of those programs are doing a great job. One of the more unique aspects of Houston's approach here is their navigation center. And this is something that actually did not exist until a few years ago. Initially, Houston did not have a navigation center or even a temporary one. They went from folks who were on the street experiencing homelessness directly into housing. But as the housing market in Houston tightened up, just like ours has, they ended up standing up a temporary navigation center. I believe they converted an old hotel or a charter school, if I'm not mistaken. No, an old hotel first, and the new one that they're building now is actually a gutted and repurposed charter school. But the way navigation centers work basically is, since we're not able to, or they're not able to take folks directly from the street and into housing, the navigation center basically is the stopgap. It's the bridge beds, as you see here. It's not meant to be a long stay shelter. Ideally, folks are there no more than a couple of weeks, although now the average rate, as you see here, is between 30 to 45 days, just because the housing market in Houston's a little tighter. And part of the housing assessment process that they've utilized to get folks housed includes things like people's personal relationships. And some of y'all who've gone and talked to folks out in camps, you might know this already. I'm sure our outreach teams can verify that this is the same dynamic exists here in the city. But the folks who camp together typically know each other and they trust each other. So they have a tendency to want to stick together. And the same was true of the folks who were experiencing homelessness in Houston. So with the housing assessment, they not just evaluate folks for, what supportive services they might need, but they try to keep those communities together, because it makes it more likely that folks are going to actually accept the aid. And they have basically a support group. So while they're all getting their permanent supportive services, it makes it more likely that they're all going to be able to succeed. Basically, you create kind of like a peer accountability network, right? Think of how you have your relationships with your own friends, right? It's the same kind of concept. So Basically, their navigation centers, I think, are a great addition. And if we pursue this, this is probably something that we'll need here sooner rather than later, just given how tight our housing market is. But the good news is, again, that I think we already have existing facilities that might be able to fit this need. So yeah, to recap here, regional collaboration, that is the biggest takeaway. And that's that basically these folks all share the best practice. They have intergovernmental coordination, unified leadership, and the most important part, the political will to not just do this, but keep it going because it's delivering results for their communities. I think we can all agree no jurisdiction should ever be taking the unhoused into other jurisdictions without that jurisdiction's consent and approval. Looking at you, Douglas County, 25% of the unhoused population per Houston are going to need supportive housing on an ongoing basis. And that's due to long-term disability or severe behavioral health issues. These are the really high acuity folks that I think a lot of us probably get calls about, where folks are out there talking to themselves and just having, issues out in public in broad daylight. Even though those folks will likely not be able to support themselves, I think we can all agree it is better to have those folks sheltered and cared for than it is to let them basically suffer out on the streets. 65% of the folks who get into this program are successful. They live without supportive services after a fashion because they either become employed or have another way to sustain their lifestyle without falling back into the continuum. And there is a failure rate, which is about 10%. But compared to everything else that I have seen, even our own Bridge House campus here, the Work First housing program that is here in Ward 4, they don't serve all the people that this program serves, and then their graduation rate, which means their success rate after a year is, I think, between 60 to 80%. So it's a pretty huge gulf there in terms of total outcomes. Yeah, again, the navigation centers, that can help us with the high cost of building shelters or a central campus. And that really should only be considered, as I mentioned earlier, if we can't expeditiously get folks off the streets and into housing. And again, the total budgetary impact cannot be understated. This is the fiscally conservative and humane thing to do. Houston's spending about $17,000 to $19,000 per unhoused person versus $96,000 is what they were spending per person per year to just manage someone's existence as an unhoused person. So basically, permanent supportive housing is both a path to housing, but also towards independence. And I think that that's a goal that we all share. So with that, I think what I'll do is I'll hand it off really quickly to Emma and Jessica, because I think they wanted to cover something on 2 slides here, according to the notes that I have. And then I can hand it off to Councilmember Coombs and Mayor Kaufman.
Thanks, Councilmember Marcano. I actually think Councilmember Coombs wanted to cover the regional approach, but really quickly just to show what's currently happening in the Denver metro region, which some of you may have sat in on some of the Metro Mayor Caucus meetings related to what MDHI or Metro Denver Homeless Initiative has, which is a regional structure where it's regional in nature, but each region is kind of doing their own thing. And so you can see that kind of on the wheel around. And so what that means is Emma and I attend meetings in Adams County, in Arapahoe County, and we have our own City of Aurora, Aurora at Home plans. And so when we all get together, we have similar but some different priorities. And that's just the nature of how things are. And obviously, very much recognizing that the city of Houston and Harris County are 2 large entities, and we have 7 counties in our metro region and oodles of different municipalities. But this is the structure that MDHI has currently come up with. We are not currently pooling money together. And again, creating policies at the different kind of more local areas. So just wanted to kind of do a compare and contrast on that. The regional collaboration was pretty phenomenal to see there. And then Councilmember Marcano, if you want to go to the next slide. There
you go.
Just kind of breaks down what that means, what each of those different smaller regional groups are doing. And what Houston said is really they took their continuum of care or their MDHI and they kind of swiped the board and they started over. So right now our MDHI board is made up of, I think, 1 local government representative, a lot of local nonprofits, some folks that have previous lived experience, I doubt there's anybody from the private sector on there, which I think is really key as well. So this is just kind of our current regional approach from MDHI that wanted to highlight as a contrast.
All right, thank you, Jessica. And Councilmember Coombs?
Yeah, thank you. So one thing that I talked to the mayor about was actually having MDHI come and do a report back. We had signed on to their, their program as a council. We agreed to get on board and we passed the resolution in support of being part of that. But we haven't heard back from them since then. So we were going to have them come back and talk about what they're doing and how that's working. But one of the things that the folks in Houston said was, what would probably work the best would be to have some folks in the region just take that leadership, just get together, 1 or 2 jurisdictions, just get together and say, here's how we want to go. Let's all get together and do it, because having strong leadership was part of what they highlighted as an important part of their success in having a regional collaboration. So I look forward to us having the conversations and looking at, as a jurisdiction, really being the strong leader that the region needs to move some things forward. And hearing from MDHI and taking our trip to San Antonio first to make sure we're collecting good data. But ultimately, I believe that we can be a strong leader given both our size and the significance of the issues that we face here in the city and in the region. So I hope that we all can figure out what's going to work for us. Because I think that's the other point that's really important, is that there's no one size fits all. We have a 7-county region with many municipalities, which is a different situation than Harris County and Houston have. But we can definitely take some key takeaways of what's effective. And I think ultimately what they've said, the regional coordination is a key to their success. The leadership and the shared commitment to the approach that they're taking forward. And I think very importantly, that folks not make this a political football. I think region-wide, that's something that we've seen. And if we want to be successful, it's going to require everyone being willing to set aside using homelessness to score political points. We should not be using people's lives to score political points. We have to set that aside and talk about what's really going to work. And one of the things that they highlighted as well was that, right, there's this polarization that tends to happen and nothing gets done on either end. It's when folks are able to come together and work in the gray area between our polar opposite approaches that we can really find the way forward together and be the kind of partners that the private sector and other entities want to engage with to support our efforts. So it's up to us to take that leadership, to collaborate, and to find the places where we can meet and get together.
Thank you, Councilmember Coombs. Mayor Kaufman?
Thank you. First of all, I want to thank Councilmember McConnell and his leadership for organizing the trip. And the fact is that we had our partners, we had a county commissioner from Arapahoe County, from Adams County. We had 2 council members from Denver and one of the, I think, not chief of staff, but
Deputy Chief of Staff.
Deputy Chief of Staff was there. So it was a very impressive group of people, a great cross section from the metro area in terms of Aurora, Denver, and some of our county partners. I really appreciated that. I think what was extraordinary about the program was their ability to bring people together and define a common purpose. And to identify the Coalition for the Homeless that covered the metropolitan area as the lead agency and to really focus all the resources to them. And it is not, it's $100 million program. $10 million comes from the private sector. I think it's probably going to create some challenges. It'd be interesting to see how they deal with it in future years, because a lot of it was one-time money, COVID relief money, ARPA money, to be able to come up with that. The $90 million from the government side of the equation. And so, and the findings were impressive by saying that 90% of those at the end of the 2 years did not apply for additional services. The one, I mean, what I'm disappointed in, and I think that I put this on Houston to be more transparent, is that when I try to get information about what happened to the people in the program, participants in the program, because they do have case management. So what's the data? How many people participated in addiction recovery? How many people participated in mental health treatments? How many people participated in job training? How many people got jobs, 6, 12, 18, 24 months? And that information was not provided. They felt that the only relevant number was at the end. But I just don't understand why they won't release those numbers, because I think they're really that I think they have a story to tell, and I think but that's an important part of the story. It was like what I mentioned to them, and I got a lot of pushback for it. That it's like a student doing a math equation without showing the work and just having the answer out there. And so I would hope that they do that. I think that another thing they could be more transparent on is the cost when they compare what the cost is somebody on the street to where they aggregated all the cost of all the programs that somebody might access, but not in somebody that has permanent supportive housing. Is that none of the wraparound services were aggregated, and that cost, whether in Medicaid, whether it's the SNAP program, none of those costs were included. And I think that you would still have a balance, I think, to their favor. But so I don't know why they don't do that. I think that, and one thing just to note when you compare, and we're going to San Antonio, look forward to that, and no preconceived notions there. But the way federal regulations, the federal government only recognizes housing first at this time, doesn't recognize work first strategy. San Antonio is a work first strategy. So in the housing first model, when somebody's housed, has permanent supportive housing, that counts as being housed, even though they're not working or they're not participating in any activities, although they have case management intersecting with them at different points on a regular basis. But in the other, in the workforce model, where there are requirements placed on somebody as a condition for the transitional housing that they receive, they are not counted as housed. And so just don't want to point that out, but I just really want to thank Councilmember McConnell for his leadership in setting up this very important trip that I think showed us an awful lot. And I want to thank Councilmember Coons for taking the time for a busy schedule to be there as well. And with that, let me open it to any questions or comments.
Mayor.
Mayor. Oh, sorry.
Councilmember Lawson.
Oh, thank you, Councilmember Zvonek. Councilmember Marcano, Coombs, and the mayor, I appreciate this report. I got one question I have for you all, or you could, if you could address, did the leadership talk about once they've got someone into housing, how do they track their success? Because you could put someone in housing and say that's the ultimate goal, but how are they tracking to make sure that they are leading to success? Are they, depending on where they're at, if it's they're getting into the house. People need to know how to pay bills. People need to understand the process. Do they track this through these landlord recruiters, or do they have case managers that to make sure? Because you can put someone in a home, but do they understand everything that goes with that? And including some of the things that they may be facing, whether, they need, help with mental health, et cetera. So do they track when they put someone into a housing first model in Houston?
Yeah, no, that's a great question, Councilmember Lawson. And the mayor, I think, just touched on it. So what I can tell you is, yes, they do track this information. They did not seem to have the more detailed information ready for us when the mayor asked his employment question, for example. But they did mention that, yeah, everyone gets a case manager, so they do track that. And they very easily track how many folks basically fall out of the program or recidivate, for lack of a better term. Because the coalition for the homeless is still the single point of contact, basically. So that's a very easy metric to track. But here, let me pull up this slide that I shared earlier, just so I can reiterate some of the services that they do offer to folks that I think have contributed greatly to the success of this program.
Councilmember Marcano, I understand that. You don't have to pull up the slide, but I guess for me, it's just understanding, I know we want to use this for, housing first model, but you put people in homes and they still have things that they have to deal with. And to me, success is how we're able to not only put someone in a house or a home, or house them, but also to help them with the issues that where they're at in their journey in terms of whatever they're dealing with.
Yeah.
So you don't have to bring that up. I saw that, but I was just wondering, how do they track that? And it looks like there's some lack of transparency there, so where you can't get all of the information.
Yeah, I just don't think they had it ready for us, but that's done through their integrated care teams. And just from my perspective, if we are able to do this regionally here, I would want that information more readily available. And I think that's something that's very easy to do.
If I can jump in just really quickly, because they did have some numbers readily available. So I think, again, yes, we can have much more data and clarity on all of the specifics, but they did say that about 27% were folks that would be eligible for SSI or SSDI. So permanent, benefits that folks have if they have a disability, or if they have other reasons that they could access SSI. So 27% of folks got connected to those benefits. That doesn't mean they weren't also engaged in other programs for mental health and other things along those lines. 20% did, while they were in the program, get jobs through vocational supports that they had as part of the program. Over 40% just needed that little housing boost. So they just needed to be helped getting into the housing and being stabilized in the housing. And then they were good to go on their own. They didn't need any additional services and supports after that. And so that's part of what we would probably see here as well, because sometimes the reason people are homeless is because they had a major emergency or disaster that just knocked out their savings, and then over time they weren't able to keep up. And so that was a significant portion of the people they served that just needed that boost, that didn't need more services on top of services on top of services. So I think that's the other thing that is important to recognize, and that we would want to track, certainly, right? How many people don't actually need anything other than some housing stabilization, versus do they need vocational supports, mental health supports, other healthcare, and community, food services, other things. So I agree with tracking clearly, having that data readily available, because I think it's important to tell the story, but they did have the basics of that data that they did provide to us.
Further questions or comments?
Mayor Zvonek.
Zvonek.
I just wanted to thank Councilmember Marcano and Mayor and Councilmember Coombs for doing this and for the presentation, Councilmember Marcano. This was really helpful. I was disappointed I wasn't able to go. I think, as the mayor mentioned, we have a trip coming up in a couple weeks to San Antonio, and I think that from what I understand of San Antonio, and we'll learn more there. And what I learned on Houston, a lot of similarities in terms of having a lead agency, trying to get away from this patchwork approach, being regional. I think the biggest, difference is going to be the idea of conditions around, participation in services in order to be in it. Because I think they have everything from the emergency shelter to a navigation center, which is your case manager. And I know that in the one of the charts, I can't remember the time frame you had. You compared the two, but this goes to the mayor's point: is that some of it is just definitions, right? I mean, between there's a study or a report put out by the United States Intergovernmental Agency Council on Homelessness, which is the only agency whose sole mission is to end homelessness, and they talk about between 2012 and 19, which I think is similar to the timeframes you said.
It was
The
11 to
change in
2020.
federal funding deprioritized transitional housing, which is what San Antonio is, towards the housing first. And so in many cases, there were programs that were just redefining the exact same program, the exact same beds, and the exact same population, and counting them, reclassifying over 100,000 people that moved from transitional to housing first. Same programs, just said they're no longer conditioned to have services, and said now you're housed. So I think that that'll be something that'll be interesting to learn, is to find out the real apples to apples comparison. But I say all this to say I'm excited that I do believe that, as diverse from a ideological standpoint on this council as we have, I do think there's going to be a lot of common areas and a desire to lead on an issue that's important to the metro area. And I think the key is going to be asking, are we changing the human condition? Because I don't think that a measurement of, does somebody have a roof over their head, do we provide them a bed and a meal, which is, of course, something that needs to happen. Meeting people's emergency needs is important. But are we changing the human condition for those who we can? And recognizing, that's why I would be interested if you have this data, but it sounds like this might not be there, is that of that 90% that they considered success rate, how many of them did they end up ultimately classifying as saying, look, they're beyond help because of some sort of, whether it's a significant mental health issue or other? Because I wonder how many of those people could have potentially been self-sufficient with treatment. I truly believe that there are a number of people who have smaller or less significant mental health issues that treat them with addiction, and over time they appear to be more more significant mental health issues. And how many of those people, because they declined and weren't required to get services, were then just classified as, well, we can't help you, and so we're going to put you into permanent supportive housing, as opposed to trying to change their conditions. And that's one of the concerns I have with permanent supportive housing or housing first.
Further discussion.
So I just want a quick response to that. So about 25% basically of the folks in the program that they encounter are the ones that they consider high acuity. But I also just want to stress that folks are never just left on their own devices, that they always have some kind of touch, whether it's with a social worker or whatever other things that they've signed up for. And what they have found is that over time, even if people are initially like, no, just leave me alone, I just want to be here by myself, the longer they realize that, no, this is for real, they're actually stable now, and these people are trying to help you, more people over time actually say yes as well. So it's not just a high level of acceptance, yeah, you're housed, awesome. It's a high level of acceptance and a high level of acceptance for the other services as well, which is what keeps people housed, because they have found that the folks who do drop out of the program, at least initially, they were the ones that rejected help, and then they end up getting evicted, or they get into a behavioral health crisis or something like that. And then they come back, and what Mark mentioned to us is that they laser focus on those people and ensure that they have more support, try a different approach, and they have found success with some of that population that might otherwise just be considered high acuity. So yeah, it's a really robust program. But thank you for that comment.
Further questions or comments?
Mayor, Councilmember Medina.
Councilmember Medina.
Yes, thank you, Mayor. Thank you, Councilmember Marcano Coombs, for getting all the information. Yeah, I'd be more than happy to. I think there's starting to be some leaning towards that. I know in foundations, I know mine in particular that I work with, we're looking at some strategies right now and how we can start to target the unhoused population. And we're talking about, looking at, potential jobs and ways to re-engage some people in communities. I know Darren Foundation has been part of that as well. I was a former trustee there, so I will reach out to that agency as well, as I think there's opportunity for us to get resources and to your point is, we could be the leader on this, and we could be the people to at least get others together, and we can start, small. And I think we can get some outside resources, so we're not, having to rely solely on city resources. I think there's community resources if we tap them that we can also, and I think community wants to help in that way.
Further discussion?
I just wanted to respond, if I could, real quick to Councilor Medina, and he's absolutely right. Their part of Houston's success was, tapping into their existing network, in addition to the other stuff that they did, eliminating redundancy. But yeah, there's a lot of community supports, and they were actually really surprised by how some folks really stood up to help make this a success. So,
further questions or comments? Seeing none, thank you again, Councilmember McConnell, for your leadership.
yep, thank you, Mayor.
Coombs for coming, as well as the work of staff in making the trip a successful one. And so, with seeing no further business before the council, the study session is adjourned. Thanks, everybody.
Good night.
Good night, y'all.